So I will start immediately. Inshallah, today I will continue, and this actually is the last topic in thyroid discussions. And inshallah, in the next sessions, I will cover revision and guidelines and the previous exam, and also the most of thyroid questions in various banks. Actually, thyroid cancer topics is very important in the final exam, and actually in most of the previous exam, about 5 questions from thyroid cancer topics. Also, I insist in every session to say tools, files, and videos are not for redistribution. And also, this is interactive presentation, so any question at any time are welcome. Please stop me and ask any question at any time, or if you want to do any comment, it is a welcome. And also, I would mention that this is the QR code for my channel in the YouTube. I already upload all previous recorded sessions, and inshallah today I will upload today's session inshallah after it is finished. So as in all of my previous sessions, I just cover, give a summary from the previous sessions, and this actually is one of the most important slide. This is the classification presented by British Thyroid Association about thyroid nodule. And actually thyroid nodule, the most challenging part for any patient presented by thyroid nodule is to exclude the malignancy. The first thing, by doing thyroid ultrasonography and search for some of suspicious feature. And suspicious feature is very important in the exam. You need to know that the microcalcification is one of the most important malignant feature in any thyroid nodule. Also intranodular vascularity, also the shape of the thyroid nodule, if it is taller than wider. This is a very important malignant feature. And also any associated suspicious lymphadenopathy or disrupted peripheral calcification or lobulated outline. This is all suspicious feature. And also you need to know that the benign features like peripheral eggshell calcification or peripheral vascularity or a pure cystic nodule, this is a benign feature. And also, after doing the risk stratification by thyroid ultrasonography, the gold standard test for assessment of thyroid nodule is fine needle aspiration cytology or biopsy. Reporting of fine needle aspiration cytology is very important, which is known as Psi classification: Psi 1, Psi 2, Psi 3, Psi 4, Psi 5. Regarding each psi, you need to know the description of each psi, because in the exam they will ask about the description and what is the action after each psi. For example, psi 1, this is a non-diagnostic, and you need to repeat fine needle aspiration cytology under ultrasonographic guide. This is very important. Psi 1C, this is assessed, and usually we need to correlate with the clinical and ultrasonographic findings. Psi 2, non-neoplastic, not a benign. This is a non-neoplastic. In most of cases of Psi 2, we just correlate with the clinical and ultrasonographic finding, and in most cases, we need not to follow up by another fine needle aspiration cytology. وطي شوية مريم وطي شوية. But in some cases, if there is a previous history of thyroid cancer or another alarming manifestation, we should repeat fine needle aspiration cytology in Psi 2. Psi 3A, this is atypical, and we need to repeat fine needle aspiration cytology with further ultrasonographic assessment. Psi 3F, this is very important because this is the description is follicular neoplasia, not follicular carcinoma nor follicular carcinoma. This is a follicular neoplasia, and the risk of malignancy is about 10 to 40%. And in some of the previous exams, they ask about this percentage. Psi4, this is a suspicious of malignancy, and we should go to hemithyroidectomy or diagnostic lobectomy because the risk of malignancy about 70%. Psi5, this is a diagnosis of malignancy, and we should go to surgical excision in a case of differentiated thyroid carcinoma, either follicular or papillary thyroid carcinoma, or doing radiotherapy or chemotherapy for anaplastic thyroid carcinoma because the patient cannot tolerate the surgery. But you should know that anaplastic thyroid carcinoma, the first line therapy is surgery. But as most of our patients cannot tolerate this surgery, so radiotherapy and chemotherapy in most cases would be the first choice. And also radiotherapy and chemotherapy for lymphoma or metastasis. And this is actually is very important how thyroid hormone senses in thyroid follicle, and what is the mechanism of action of anti-thyroid drugs, carbimazole or methimazole or propylthyracil, intrathyroidal inhibition of iodine oxidation, organification, coupling, thyroglobulin biosynthesis, and follicular cell growth. And don't forget that the propylthyracil has a unique mechanism of action more than carbimazole or methimazole that inhibit dehydrogenase type 1, which is responsible for extrathyroidal conversion of T4 to T3. So propylthyracil inhibit the extrathyroidal conversion of T4 to T3 in the peripheral tissue. And this also is very important part and table in the exam. This is how to differentiate between TSH secreting pituitary adenoma versus resistant to thyroid hormone. The most important thing is TSH response to TRH. In TSH show a blunt response, but in the resistant to thyroid hormone increased like in normal physiological pattern. The TSH response to T3 no changes the TSH but decrease in resistant to thyroid hormone like in normal physiological pattern. Alpha subunit, this is the best biochemical test in assessment of TSH versus resistant to thyroid hormone, which will be elevated in about 65%. Pituitary MRI is not the first option in differentiation between TSH and resistant to thyroid hormone because there are a pituitary incidentaloma, which is maybe non-functioning pituitary adenoma, not TSH secreting pituitary adenoma. So a pituitary MRI is important if as a second choice after alpha subunit. Actually, in most of the TSH are macroadenoma, about 70%, but in the resistant to thyroid hormone, the pituitary MRI may be normal or may be pituitary incidentaloma. And don't forget that in resistant to thyroid hormone, usually there is another family members presented by the same condition. Also, both of them can be presented by mild clinical thyrotoxicosis. And also, this is a very important tool to assess Graves' orbitopathy, which is known as a clinical activity score. How to manage Graves' orbitopathy regarding by a clinical activity score and severity. So a clinical activity score, this is a 7 points. Each one contain 1 point. If this score more than or equal to 3, this is active Graves' orbitopathy, in which contains 2 of pain, 2 redness, 3 swelling. Pain, spontaneous retrobulbar pain on attempt upward or downward gaze, redness for eyelid or conjunctiva, swelling for eyelid, conjunctiva or caruncle or oblique. So if anyone has 3 or more clinical activity score, this is active Graves' orbitopathy. Another one is the classification of Graves' orbitopathy according to the severity: mild Graves' orbitopathy or moderate to severe Graves' orbitopathy or sight-threatening or very severe Graves' orbitopathy. How to differentiate between mild to versus moderate to severe? By 5 items: eyelid retraction, exophthalmos, soft tissue involvement, extraocular muscle involvement, corneal involvement. Regarding this point, we can classify our patient to mild or moderate to severe. And sight-threatening Graves' orbitopathy, this is a thyroid optic neuropathy or corneal breakdown. And this is actually is emergency condition, need a rapid referral to ophthalmologist. And this is another table from a New England Journal of Medicine to differentiate between mild and moderate to severe Graves' orbitopathy. This is a very important table, and actually we discuss it in more details in Graves' orbitopathy session. And this is how to manage Graves' orbitopathy. This is very important, and you need to restore and maintain euthyroidism in all patients rapidly as possible, usually using anti-thyroid medication. Advise people, and this is very important, to stop the smoking, use of artificial tear in most of patients, assess disease severity and or activity. If the disease is mild Graves' orbitopathy, just we can consider selenium for 6 months. But if there is affection for quality of life with mild disease, we can give intravenous glucocorticoid. Don't forget that intravenous glucocorticoid, this is updated item, because in the previous editions and the previous guidelines they can recommend an oral high dose glucocorticoid, but nowadays intravenous glucocorticoid is the first choice. Moderate to severe Graves' orbitopathy, if there is active Graves' orbitopathy, intravenous glucocorticoid is the first choice. If inactive Graves' orbitopathy, so we can go to rehabilitative surgery if needed. Sight-threatening disease, we should give intravenous glucocorticoid for a few days. If no improvement or poor response, after 2 weeks we should go to surgical decompression and later on rehabilitative surgery. And this is very important to phenomenal Wolff Chaikoff effect, Chaikoff leading to hypothyroidism. Don't forget that is usually occur in the normal thyroid, and you can occur in the Graves' disease causing decreased thyroid hormone synthesis. So in most of our patients during a preoperative preparation for Graves' disease, we give a high dosage of iodine to work as a Wolff-Chaikoff effect, leading to decrease thyroid hormone synthesis by what is known as Wolff-Chaikoff effect. And actually this is takes a few days or 10 days in most of cases, leading to iodine-induced hypothyroidism. Later on will escape after 10 days and may cause normal thyroid hormone synthesis. Jod-Basedow effect, this is usually seen in abnormal thyroid gland, usually occurs after ingestion of extra iodine or diet or contrast or amiodarone and causing iodine-induced hyperthyroidism, and this is actually the mechanism in amiodarone-induced thyrotoxicosis type 1. Amiodarone-induced thyrotoxicosis is very important in clinical practice and in exam, because in each exam they will ask about 2 questions about this amiodarone-induced thyrotoxicosis, and actually we should know how to differentiate between type 1 and type 2, which is more common. Type 1 usually due to the Jod-Basedow syndrome usually occur in a clinically abnormal thyroid gland. Usually there is a goiter or thyroid autoantibody, and usually radioiodine uptake usually is normal or low or high. Versus amiodarone-induced thyrotoxicosis type 2, in which radioiodine uptake usually is 0% uptake, near 0 uptake. Thyroglobulin usually is very elevated in type 2, but don't forget that in late hypothyroidism will occur in, maybe occur in type 2 but not occur in type 1. Vascularity, and this is the most important to differentiate between type 1 and type 2, is continuous flow Doppler sonography, vascularity by Doppler. And the second choice for differentiation between type 1 and type 2 is radioiodine uptake. And don't forget that type 1 managed by carbimazole, but in type 2 usually managed by corticosteroid. Type 2 usually need no definitive thyroid treatment, but in type 1 we should go to the permanent treatment by surgery as a first choice, or radioactive iodine ablation as a second choice. How to manage amiodarone-induced hypothyroidism? Actually, if there is underlying chronic autoimmune thyroiditis, we should go with levothyroxine. If normal thyroid gland, if we can stop amiodarone, so we will stop and reassess after 1 or 2 months. If the patient returns to euthyroid, just a follow up. If still hypothyroid, we should treat by levothyroxine. If we cannot stop amiodarone in this situation, we should treat by levothyroxine, especially if overt hypothyroidism. If TSH is more than 20, in this situation, we should treat by levothyroxine. If subclinical hypothyroidism, we can wait and see according to the individual condition. If the patient is cardiac or symptomatized, so we should treat a trial of a treatment. If not, we can wait and see. No, interleukin 6, Dr. Sadeh asked about a few questions on interleukin 6 in the hyperthyroidism. What is the significance and is it a valid investigation for hyperthyroidism? In clinical practice and in exam, no. And this is how to treat amiodarone-induced thyrotoxicosis from the guidelines. And actually, in the next session, inshallah, in the next Friday, I will cover most important guidelines, and I will cover amiodarone-induced thyrotoxicosis guidelines published in 2018. And the most important in amiodarone-induced thyrotoxicosis type 1, stop amiodarone if feasible. After that, we will treat by carbimazole or mesimazole plus or minus sodium perchlorate, and after rendering the patient euthyroidates, we should go to definitive thyroid treatment by thyroidectomy or radioactive iodine. In type 2, in this situation, amiodarone can be continued according to the guideline, and the patient treated by oral glucocorticoid. Most all of the patient will remit and just need a follow-up. But actually, in clinical practice and in some of situations in the exam, we cannot differentiate between type 1 and type 2. In this situation, we will combine the treatment by cyanamide plus oral glucocorticoid. If rapid improvement in this situation, this is a type 2, I will stop cyanamide. How to know the rapid improvement? By decrease of T3 by 50% after 2 weeks of initiation of oral glucocorticoid and cyanamide. So, if rapid improvement of mixed type amiodarone-induced thyrotoxicosis, this is denoted type 2 amiodarone-induced thyrotoxicosis, and in this situation, I will stop carbimazole. If no rapid improvement in this situation, I will suggest this is a type 1, and I will stop amiodarone, gradual decrease of glucocorticoid, and continue anti-thyroid medication, and I will add the sodium perchlorate if not prescribed for the patient. So this is a very important slice from the previous sessions, and also I will give some of questions from a previous session, but actually before starting of my prepared 5 questions, I will give this question from British Medical Journal on examination 2022, and actually presented in the previous edition of on examination. And actually this exam is asked by some of my colleagues in the group. I don't actually know who asked this question, but this is a very important question. This is a 72-year-old male presented with 2 months history of agitation and weight loss. 4 months previously, he was admitted with paroxysmal AF and was commenced on amiodarone, 200 milligram daily. Since then, he has no further palpitation, no past history of hypertension. He has a past history of hypertension, which he take amlodipine. On examination, he looked well, slight tremor of outstretched hand. The pulse is okay, blood pressure is hypertensive, no goiter, and investigation in ESR is normal, creatinine is okay. Free T4 is elevated, free T3 is normal, TSH is low, thyroid autoantibody is negative. What is the most appropriate treatment for this patient? Start carbimazole, stop amiodarone, treat with radioactive iodine, start atenolol, start prednisolone. What is your choice?
Prednisolone.
What?
Thyroid and prednisolone, thyroid and autoantibodies are negative.
Yes. So you recommend the prednisolone as a type 2.
Yes.
Actually, this is a sum of conflicting question because when we stop amiodarone, yes.
Maybe carbimazole because ESR is more or less 18.
The patient now has no.
My recommendation is stop amiodarone.
Actually, to differentiate between type 1 and type 2 in this clinical case scenario is very difficult actually because the thyroid autoantibody may be presented in a general population. So cannot differentiate between type 1 and type 2 accurately because the most accurate to differentiate between type 1 and type 2, as I mentioned, is Doppler sonography and radioactive iodine uptake. But actually in this scenario, on examination it choose to stop amiodarone actually, and this is the conflicting to someone. They choose stop amiodarone. Why to stop amiodarone? They mentioned that the patient already controlled in a small dose of amiodarone, and also I think thyrotoxicosis is not very significant to prescribe prednisolone versus carbimazole. And one of the most important to know that what is mentioned in the guideline. And actually, this is from the European guideline, latest guidelines about amiodarone, and I want to know that the diagnosis of amiodarone-induced thyrotoxicosis usually require increased serum free T4 and free T3. In our case scenario, free T3 is normal. So this is a very important hint. And they mentioned in the guideline, in a rare case of amiodarone-induced thyrotoxicosis, free T3 may be normal, but is this in a case of severe non-thyroidal illness? So I think in our case scenario, I cannot be sure 100% this is a case of amiodarone-induced thyrotoxicosis. It may be amiodarone effect. And in this situation, as the patient is clinically stable and amiodarone is not a significant drag and not severe arrhythmia in our patient, the patient is just presented by paroxysmal attacks of AF, which is not a life-threatening condition. In this case scenario, we can stop amiodarone safely. And actually in the guidelines, they give a very important paragraph about can amiodarone be continued in some cases of amiodarone-induced thyrotoxicosis. Actually, I will discuss it in the next session, inshallah, in the next Friday. But they mentioned that the decision should be individualized with respect of risk stratification, taken jointly by specialized cardiologist and endocrinologist. Amiodarone should be continued in a critically ill patient with life-threatening cardiac disorder responsive to the drug. Continuation of the amiodarone treatment is probably also visible in type 2, as this form is often self-limiting. The problem is more complex in type 1, and many endocrinologists favor amiodarone withdrawal if feasible from the cardiological standpoint. And this is a very important hint when to stop and when not to stop. And actually, in our clinical exam, this scenario, if free T3 is elevated, I will continue amiodarone actually, and I will start prednisolone because it is the most common is amiodarone-induced thyrotoxicosis type 2. So I think this is amiodarone effect, not amiodarone-induced hyperthyroidism, as in mentioned in the guidelines. In the amiodarone-induced thyrotoxicosis, both free T4 and free T3 must be elevated. And actually in the previous recorded session with Dr. Mahmoud Aizad and Ibrahim Al-Ali with Dr. Khaldoun, we have a lot of debates about this point, when to stop amiodarone, because in some of the questions they choose stopping amiodarone. And actually I noticed that if both free T3 and free T4 are elevated, I cannot stop amiodarone except in minimal cases. And actually this is a very important algorithm, and actually I discussed it since a few minutes. So I will go to some of important question, and which one of the following ultrasonographic feature is suggestive of malignant? Yes?
there is another point in the previous question. This
Yes,
patient has
Dr.
paroxysmal
Najah,
AF.
Dr. Najah, she asked the previous question in the WhatsApp, and actually I did not remember who sent it. So, Dr. Najah.
The previous patient has paroxysmal AF, not persistent AF. And
Yes.
in the question, the patient is stable, not in AF. So there is
Yes.
no role for continuing amiodarone.
Yes, I am with you. Actually, if the patient have a life-threatening condition, we cannot stop amiodarone. Actually, in all cases, if either type 1 or type 2 or hypothyroidism. But as the condition is a minimal arrhythmia, which cannot affect mortality or morbidity, so stopping amiodarone is one of the most important next step in this case scenario.
The first line is beta blocker, not amiodarone.
Yes, yes, and actually in the explanation in the own exam they mentioned that if we can add, for example, citalol, which is one of a broad spectrum antiarrhythmic drug and beta blocker, so it is ideal beta blocker in these cases of paroxysmal AF. So this is another question about which one of the following ultrasound feature is suggestive of malignant nodule. Of course, blind your eyes and to choose microcalcification if it is presented. But here, eggshell type calcification in the periphery is it? Yes, yes, yes. So the most important eggshell type calcification is a benign feature. Taller than wider shape is a malignant feature. So this is a malignant feature, solid hypoechoic nodule, microcalcification, irregular margin, intranodular vascularity, taller than wide. Taller than wide is one of the malignant feature for papillary or medullary thyroid carcinoma. This is a 32-year-old male presented by thyroid clinic by painless lump in 4 weeks before. So this is a rapid increase in the size. The patient already type 2 diabetes and hypertension with a family history of adenomatous polyposis. This is a risk factor. The body mass index is increased. Firm thyroid nodule is palpable. Thyroid sonography risk stratification is U3, which is indeterminate risk pattern by U classification. The fine needle aspiration cytology was reported as Cy2, which is, what about Cy2? Non-neoplastic. He was referred for urgent ultrasound for the thyroid gland. Which one of the following is the most appropriate management step?
Repeat fine needle aspiration.
Why to repeat? Why not to discharge from follow-up as you Cy2 is non-neoplastic?
Because of risk factors.
Can be discharged and follow.
Yes, Dr. Mahawish, the patient is high risk.
Old, high risk.
Yes. Why high risk is this patient? What is the risk factor?
Adenomatous polyposis, family history.
Yes.
Old age.
Age.
Family history.
A rapid increase in the size of the nodule within 4 weeks. The family history of adenomatous polyposis. The firm thyroid nodule. U3. This is a risk factor for thyroid nodule. So this patient cannot be discharged from follow-up. We should repeat fine needle aspiration cytology. When to repeat?
After 6 months.
After 6 months. Actually, this is a patient, I will not repeat fine needle aspiration cytology immediately like Cy1, but we should repeat it after 6 months. So don't forget that U2, we can repeat it if there is a family if a risk factor, and also U3 can repeat it if there is a high suspicious of thyroid nodule. And actually this is algorithm is very important, and actually this is our patient Cy2. In this situation, non-neoplastic review and the clinical ultrasonographic level of suspicious. If high level of suspicious for thyroid cancer, we should repeat ultrasonographic guided fine needle aspiration cytology or MDT discussion. If low level of clinical and ultrasonographic suspicious for thyroid cancer, not like our patient, we go to no follow-up. So in our patient side 2, there is a high level of suspicious, so we should repeat fine needle aspiration cytology. So this algorithm is very important in clinical practice and in the exam. Another question, a 32-year-old woman was admitted to medical assessment unit with nausea, vomiting, dehydration, and intermittent headache and visual blurring. If free T3 is elevated, if free T4 is elevated, TSH is normal, non-suppressed. Which one of the following tests may be useful to diagnose TSH?
That's B.
Yes, B. Planted or absent response to RH stimulation.
A blunt response. Why not A? A 3 millimeter lesion in the pituitary MRI. This is a TSHoma.
Incendiaroma is common.
Yes, pituitary incendiaroma is common, and usually TSHoma is a macroadenoma. Most of cases is a macroadenoma. What you decrease the alpha subunit?
No, high.
It
Elevation.
is elevated. TSHoma usually the alpha subunit is elevated. What about a low sex hormone binding globulin?
Also elevated.
What about negative gene sequence for thyroid hormone resistant beta gene?
That's for thyroid resistant.
Non-significant also.
Yes, because all of us have a negative gene sequence for thyroid hormone resistant beta gene. So if it is a positive gene, this is a diagnostic for thyroid hormone resistance syndrome. So a blunt or absent response to TRH stimulation is the best one, and this table is very important to differentiate between these two very important conditions in the exam. Another question about recurrent Graves' disease, and the patient choose a radioiodine ablation. What is the dosage of radioiodine in most appropriate in uncomplicated Graves' disease? And this is by megabecquerel.
400 to 600.
B, 400 to 600.
Yes, this is a 4 to 600. Actually, this is a table is important from our book. Most of them about 5 to 600. And of course, a toxic multinodular goiter need a larger radioactive iodine dosage. And if recurrence of severe Graves' disease, we need a larger dosage. Actually, Graves' disease need 4 to 600 megabecquerel. And this is a question, which one of the following is used as a parameter to assess the clinical activity score in patient with Graves' disease?
One. Erythema. Eyelid erythema.
Eyelid erythema.
So don't forget to pain,
to
redness, and 3 swelling. So to pain, to redness, 3 swelling. Eyelid erythema and eyelid erythema of the conjunctiva, swelling of the eyelid and conjunctiva. This is 4 items from 7 items. Intraocular pressure, thyroid hormone level of the TSH receptor antibody in lead lag is not a points in this score. So this is a previous questions from previous sessions, and inshallah I will start the thyroid cancer session. This is a very important session. I will cover epidemiology of thyroid cancer, etiology, and the risk stratification, the staging, and the prognostic factor, and what is known as papillary microcarcinoma. Don't forget that microcarcinoma means size less than 1 centimeter or 10 millimeter. So pituitary microadenoma is less than 10 millimeter. Papillary microcarcinoma is a papillary carcinoma less than 10 millimeter. And papillary thyroid carcinoma, which is the most common thyroid cancer, follicular thyroid cancer, which is the next most common after papillary thyroid cancer, and of course, the papillary and follicular thyroid cancer are known as differentiated thyroid cancer. So when we speak about differentiated thyroid cancer, we mean papillary or follicular thyroid cancer. Medullary thyroid cancer, which is originated from the C cell. And don't forget that calcitonin is a marker for medullary thyroid cancer, and we will discuss it in more details with MEN2. And what is known as non-differentiated thyroid cancer, which is anaplastic thyroid cancer, which is more aggressive thyroid cancer, anaplastic thyroid cancer, and also we will discuss thyroid lymphoma. The epidemiology of thyroid cancer is very important. Usually, thyroid cancer usually presented as a solitary nodule, solitary thyroid nodule. But don't forget that in multinodular goiter, the risk of malignancy in multinodular goiter is the same as the risk of malignancy and solitary nodule. Previously, a lot of years they mentioned that multinodular goiter is a benign condition. But actual risk of malignancy in multinodular goiter is the same as solitary nodule. Thyroid cancer are rare and represent about less than 1% of all cancers, and the mortality is less than 0.5%. We have 4 types of cancer: papillary, follicular, medullary, and anaplastic, and thyroid lymphoma. The incidence is about 1 to 10 per 100,000 population, and of course the risk of thyroid cancer is increased in the female. The papillary and follicular thyroid cancer, which is known as differentiated thyroid cancer, represent about 60 to 90% of the total thyroid cancer. And as I mentioned previously, papillary thyroid cancer is the commonest thyroid malignancy and represent about 90%, about 50 to 90% of differentiated follicular derived thyroid cancer. The papillary thyroid microcarcinoma, which is papillary carcinoma less than 1 centimeter, are found in about 4 to 36% of the adult postpartum. And this actually need represent a very benign pattern of thyroid malignancy. In most of papillary thyroid cancer diagnosis occur usually in the age 30 to 50 years, and the follicular thyroid cancer usually occurs in the elderly population. The annual increase rate is about 3% of differentiated thyroid cancer. The follicular thyroid carcinoma represent about 15% of all thyroid cancer. The frequency of follicular thyroid cancer increased in the iodine deficient endemic goiter area more than the papillary thyroid cancer. The malignancy of the older people is follicular, usually follicular. The big incidence of follicular thyroid cancer 40 to 60 years, and more commoner in females. The medullary thyroid carcinoma occurs in both sporadic or hereditary form. And hereditary medullary thyroid carcinoma is autosomal dominant trait, and we will discuss it in more details with men type 2, either A or B. And also medullary thyroid carcinoma may be presented as a familial medullary thyroid carcinoma, and it can be diagnosed before a clinical presentation by genetic and biochemical screening. In this situation, we should go to the total thyroidectomy before age of 5 in case of men type 2A, and before the age of 1 year of life in men type 2B. Anaplastic thyroid cancer is very rare and more frequent in population with endemic goiter. Thyroid lymphoma is also uncommon, but it represents about 2% of extranodal lymphoma and more common in the female, and usually more common in patients with autoimmune Hashimoto thyroiditis. In any patient presented by autoimmune Hashimoto thyroiditis and presented by increase or rapid enlargement of thyroid gland, we should suspect lymphoma, because lymphoma is more than 70% fold increase in a case of Hashimoto thyroiditis. Actually, hereditary means this is autosomal dominant condition, which is represented in once present in a parents, one of the parents, it will be inherited as autosomal dominant condition. All children will be present, 50% of children will be presented by medullary thyroid carcinoma. But familiar medullary thyroid carcinoma, this is not autosomal dominant. The pattern is not Mendelian hereditary pattern, but it is more common or runs in family. Like for example, autoimmune thyroid disorders, all of autoimmune thyroid disorders runs in family, but not has a specific pattern in which we can conclude that this child has a risk of inheritance of this disorder by significant percent. And actually we'll discuss it in a separate chapter, inshallah. So a classification of thyroid cancer, we should know that differentiated thyroid cancer, papillary, which represent about more than 80% of thyroid cancer, follicular, which represent about 10%, and anaplastic, which is known as undifferentiated thyroid cancer, represent about 1 to 5% of thyroid cancer, and this is the more the most baddest prognosis in thyroid cancer. Medullary thyroid cancer represent about 5 to 10%, and this is originated from the C cell, and the most important marker for medullary thyroid cancer is calcitonin. And another one is a thyroid lymphoma, which represent about 1 to 5% of thyroid cancer, and more common in a patient of autoimmune hypothyroidism, Hashimoto's thyroiditis. And this table summarizes the most different important points to differentiate between papillary, follicular, and anaplastic. The age of presentation, actually, papillary thyroid cancer presented in a younger age than the follicular, and anaplastic usually is a cancer for the elderly. Papillary thyroid cancer is spread by lymphatic, but the follicular and anaplastic mainly hematogenous. The prognosis of papillary and follicular is good, but anaplastic thyroid cancer is has a bad prognosis, very poor prognosis. How to treat papillary and follicular? Usually by near total thyroidectomy, followed by TSH suppressive therapy, and for high risk patient we should go to radioactive iodine remnant ablation, and we will discuss it in more details inshallah today and in the next session inshallah when we discuss British Thyroid Association guidelines about thyroid cancer published in 2014. So how to treat papillary and follicular cancer? Total thyroidectomy, TSH suppressive therapy by thyroxine as a suppressive therapy, not replacement therapy, high dosage of thyroxine to suppress TSH, and also radioactive iodine ablation to ablate remnant part of thyroid tissues. And then the follow-up usually by post-operative total body radioiodine scan, which whole body scan with thyroglobulin measurement in both follicular and papillary differentiated thyroid cancer. Anaplastic usually treated by a total thyroidectomy with lymph node clearance, but most cases cannot tolerate a total thyroidectomy, so external beam irradiation and chemotherapy can be alternative to total thyroidectomy. Which one of the following feature is suggestive of suspicious nature of thyroid nodule? And this is from latest edition of Study BRN. Which one?
4.
Number 4.
Yes, microcalcification this is one of the most important suspicious feature. Once you see microcalcification, this is a very important alarming feature of thyroid malignancy. And actually in the British Thyroid Association guidelines, they did not use the size as a marker in which we should do fine needle aspiration biopsy like the American Thyroid Association recommendation or thyroid recommendation. Once you see microcalcification in any thyroid nodule, any size, we should go to fine needle aspiration cytology according to British Thyroid Association recommendation. So, microcalcification is a very important suspicious feature. Etiology of thyroid cancer and the risk factors for development of thyroid cancer. Radiation is one of the most important etiological causes of thyroid cancer. Actually, external radiation does not appear to be thyroid carcinogenic. It does up to 100 to 500 seem to produce thyroid cancer at a rate of less than 0.5% per year. No evidence that therapeutic or diagnostic radioactive iodine ablation can induce thyroid cancer, even in children actually, but is not recommended in children less than 5 years of age. External radiation at an age less than 20 years is associated with increased risk of thyroid nodule development and thyroid cancer, which is mostly papillary thyroid carcinoma. And this is actually is not 100% evidence, but actually regarding Chernobyl disaster, which is radioactive followed from the Chernobyl, resulted in increased 4.7-fold increase in papillary thyroid carcinoma, especially in children less than 10 years of age. And actually there is a minimal latent period for thyroid cancer development after exposure, which is short as 4 years. And the vast majority of these cancers were papillary thyroid carcinoma. And actually this is a question in my previous exam in 2018. They ask about the commonest cancer that develops after Chernobyl disaster, which is papillary thyroid carcinoma. And one of the important hint is iodine supplementation has resulted in a decrease in the incidence of follicular thyroid carcinoma and also in the papillary thyroid carcinoma. So in anyone exposed to radioactive material, iodine supplementation can decrease the development of follicular and papillary thyroid cancer, and this is a question in a previous exam. Molecular alternation in thyroid cancer is important, and actually in some exams they ask a question about which is the most molecular gene representative in some of the cancers. Rearrangement of a rearranged tyrosine kinase gene RET, and another one activating mutation of the BRAF gene, and activation mutation of the RAS gene. And actually in the previous year exam they asked about a question about the most common form of papillary thyroid cancer gene mutation, RAS or BRAF. Actually BRAF is the most common mutation in papillary thyroid cancer, and the prevalence of a BRAF mutation was 30 to 80%, and I will discuss it later in the next slide. The most frequent gene mutation or activation RAS mutation. This is a follicular thyroid cancer, and less frequently activation of a BRAF mutation. So RAS and BRAF occurs in papillary and follicular, but in the papillary BRAF is the most common, in follicular RAS is the most common. Actually in the papillary BRAF is the most common, in follicular rather than RAS, PAX8 and BPAR gamma 1 fusion is the most common gene mutation. This is oncogenes and the tumor suppressor gene for thyroid neoplasia, and this is actually important because in some exam they ask about a question about this. You should know that papillary thyroid cancer BRAF gene mutation, follicular thyroid cancer PAX8, BPAR alpha 1 gene mutation, and also RAS mutation. In anaplastic thyroid cancer, TP53 mutation, and medullary thyroid carcinoma, RET proto-oncogene mutation. And actually, medullary thyroid cancer, we will discuss it in more details in the separate chapter. And this is for malignant neoplasia, papillary thyroid cancer BRAF, follicular thyroid cancer PAX8, anaplastic TP53, medullary thyroid cancer RET gene. For benign neoplasia, autonomous toxic nodule, TSH receptor activation mutation, GS alpha mutation, follicular adenoma, RAS mutation. This is the most important oncogene and tumor suppressor gene you should know and memorize before the exam. Prognostic factors, staging and risk stratification in differentiating thyroid cancer is very important actually in clinical practice and in exam. Not very important actually, but at least in your clinical practice, you need to know the prognostic factor and the risk stratification of differentiated thyroid cancer. Of course, in differentiated thyroid cancer, a 10-year survival is very high, about 80 to 90% survival rate after 10 years, but 5 to 20% of patients develop local or regional recurrence. So, the recurrence rate to some extent is high, but actually the prognosis is very good. So, the follow-up of patient of differentiated thyroid cancer usually is lifelong, usually for life. About 10 to 15% distant metastasis, and also 9% of the patient with a diagnosis of thyroid cancer die from the disease. And actually, to treat thyroid cancer, we should a multidisciplinary thyroid cancer team to discuss. And this should constitute a compromise from surgeon, endocrinologist, oncologist, and a nuclear medicine physician. This is an important question from the Hurthle book. Which one of the following are considered to be a risk factor for development of thyroid cancer? Female gender, men type 1, obesity, radial thyroiditis, type 2 diabetes mellitus.
Female gender. Female gender.
Actually, female is protective. Male gender is a risk factor.
No, male gender.
Thyroid cancer is more common in the females, but the male is a risk factor for bad prognosis. What about men type 1?
No, it should be men type 2, not men type 1.
Yes. So men type 1 means pituitary, parathyroid, pancreatic. No relation to thyroid. And this is what I want to hint about. Men type 2 is a risk factor for development of medullary thyroid cancer. But men type 1, this is a pituitary adenoma, parathyroid lesion, and pancreatic lesion. So what is the risk factor for development of thyroid cancer? Actually, obesity, like Dr. Rana said. So, obesity is a risk factor for development of thyroid cancer. And this is men type 1 and men type 2A and B. And this is very important to know that men type 1 is not thyroid lesion. Has no thyroid lesion, just BPB, pituitary adenoma, parathyroid hyperplasia, pancreatic tumor. And this is from a Hurthle book. The risk factor for thyroid cancer: history of nickel radiation, endemic goiter, Hashimoto thyroiditis, increase the risk of lymphoma, family or personal history of thyroid adenoma, Cowden syndrome, which is very important in exam, familiar adenomatous polyposis, like our case, the previous case, familial thyroid cancer, and obesity. And the most important in bad prognosis, thyroid nodule is more likely to be malignant in age less than 20 or more than 60, firm or solitary non-toxic nodule, rapid growth, hoarseness of voice, palpable suspicious cervical lymph node, and microcalcification on sonography. So, what is the predictor for thyroid cancer? Age is one of the most important predictor. So, increased, of course, with age. If the age is less than 40, this is a benign condition. If the age is more than 40, risk of recurrence and the risk of invasion is more than if the age is less than 40. And also, if the age is less than 10, this increases risk of cancer. The male gender is reported as independent risk factor in some but not all studies. And very important, the histological pattern of thyroid cancer. The prognosis of papillary thyroid cancer is better, but we have some of poorer prognosis associated in papillary thyroid cancer histological types like tall cell and columnar cell. And actually this is very important in risk stratification, and I will discuss it later on. So the histological types of papillary thyroid cancer, tall cell, columnar cell, has a poorer prognosis than non-taller cell and non-columnar cell. Also, a degree of cell differentiation and vascular invasion have a bad prognosis. And another one, poorly differentiated and oncolytic follicular Hurthle cell carcinoma are also associated with poorer outcome in follicular thyroid carcinoma. And of course, as all of us know, tumor extends, extrathyroidal invasion, lymph node metastasis, and distant metastasis all are important prognostic factor in thyroid cancer.
Doctor,
Yes?
I think what I know that women are at higher risk to develop thyroid cancer, but the
Yes.
prognosis is bad than women. The prognosis itself.
Yeah, the prognosis is bad in male.
In male, but
the thyroid cancer is more common in females.
It's more common in female, yes.
Yes. So all thyroid disorders, actually most all of thyroid disorders are more common in females except the Graves' orbitopathy, which is represented in males and females as equal percentage. But actually, autoimmune thyroid disorders, all of it are more common in the females. The thyroid nodule are more common in females. The thyroid cancer are more common in female, but more bad prognosis in males, not in females. The thyroid cancer.
Right, thank you.
So the staging system is very actually difficult in clinical practice, but at least we should know that there are a lot of staging system classification for thyroid cancer and differential thyroid carcinoma. The most easy one is TNM, which is tumor size, node metastasis, and distant metastasis M. And another one which is AMES and MESES and ORETIC and so on. So this is yes, Graves' orbitopathy is severer in the males. Yes, yes, Dr. Hanna. The post-operative stratification and the risk of recurrence of differential thyroid cancer is very important actually, because according to the risk stratification, we will go if our patient will receive radioactive iodine ablation or not. And also, according to this risk stratification, the target of the TSH depends mainly on this risk stratification. For differential thyroid cancer, we should classify our patient according to be low risk or intermediate risk or high risk. In a patient, for example, high risk patient, we should do total thyroidectomy, suppressive therapy. The target of the TSH should be less than 0.1, and also the patient should receive radioactive iodine remnant ablation therapy. But in the low risk patient, for example, low risk patient, we can do total thyroidectomy, and also we can do lobectomy alone. And most of this, all of low risk patients need not to receive radioactive iodine ablation, and the target of the TSH low normal TSH in a low risk patient. In indeterminate risk, intermediate risk, in this situation we can give radioactive iodine ablation therapy, and also the target will be lower than the lower risk patient but not suppress TSH like the high risk group. Who will be classified as low risk? If there is no local or distant metastasis, All macroscopic tumor has been resected, which is mean R0 or R1 resection, and this is pathological definition, and I will mention what they mean by R1, R0, and R1, R2. R0 mean complete tumor resection was achieved with no tumor cell within 1 millimeter of resection margin, but R1 mean distance of less than 1 millimeter between tumor cell and the resection margin. R2, this is a macroscopic residual tumor and represent a high risk patient. If there is a R2, which mean incomplete macroscopic tumor resection, this is a high risk patient and need radioactive iodine ablation and suppressive therapy. So, in low risk, no local or distant metastasis, all macroscopic tumor has been resected, no tumor invasion, the tumor does not have aggressive histology. What does we mean by aggressive histology? Not tall cell or columnar cell, as I mentioned in papillary thyroid carcinoma, diffuse sclerosing papillary thyroid carcinoma, poorly differentiated elements, or angio invasion. This is a lower risk. What about the high risk? High risk, the patient has the following criteria: extrathyroidal invasion, incomplete macroscopic tumor resection R2, or distant metastasis. This is a high risk. What is not belong to low risk or high risk is intermediate risk. Intermediate risk means microscopic invasion of the tumor, cervical lymph node metastasis N1A or N1B, a tumor with aggressive histology, which is tall cell or columnar cell papillary thyroid carcinoma, or diffuse sclerosing papillary thyroid carcinoma, or poorly differentiated element, or angio invasion. So this is a very important to classify your patient to low risk, indeterminate risk, or high risk group, because a treatment will be different according to this risk stratification. Papillary thyroid microcarcinoma, and actually in a previous exam they ask about a tumor size in which we define papillary microcarcinoma in 2022. So the microcarcinoma mean a tumor less than 1 centimeter or less than 10 millimeter or less in diameter. The papillary microcarcinoma rarely progress to clinical apparent thyroid cancer with advancing age. This is very important. So, papillary microcarcinoma can be multifocal. Cervical lymph node metastasis from papillary microcarcinoma range from 4 to 18%. And actually, exposure to irradiation increases the likelihood of development of papillary thyroid carcinoma, but this is usually is. And now, Dr. Barakat, what about voice?
Better now.
Okay. So, papillary microcarcinoma is a slow growing lesion and actually carries a very, very good prognosis and usually treated by surgical lobectomy. And in this situation of microcarcinoma, no need to radioactive iodine ablation and no need to suppressive therapy, just replace by thyroxine. The target of the TSH is lower normal, lower half of the normal. No evidence that targeting TSH below the reference range improves the prognosis. So in papillary microcarcinoma, the treatment is ipsilateral lobectomy, no suppressive therapy, just replacement therapy, and also no need to radioactive iodine ablation. And what about my voice, Dr. Shavan? Okay. Papillary thyroid carcinoma, this is a very important in the exam and the clinical practice. This is a non-encapsulated. A lot of variants of papillary thyroid carcinoma, follicular variant of papillary thyroid carcinoma, papillary dorsal columnar cell and tall cell and diffuse sclerosing. Don't forget that the columnar cell, tall cell, diffuse sclerosing is a bad prognosis types of papillary thyroid carcinoma. And the nuclear feature include a large size with a pale staining, a ground glass, what is known as orphan ani-eye nucleus, and deep nuclear groove. This is not very important, but what is the important, it is usually 15 to 20% have local extrathyroidal invasion, and the metastasis about 1 to 2% of the patient occurs via lymphatics. And usually the patient is classified as low risk if the age is under 45 years. So in a young patient, any patient presented by papillary thyroid cancer will be classified as a low risk, which is stage 1 or stage 2 if under age 45. Dr. Hana mentioned that ipsilateral lobectomy even in a multifoci more than 5, according to the American Thyroid Association. So we should classify our patient to low risk, which is stage 1 if the patient under 45, no metastasis, tumor size less than 2 centimeter, and in this situation the patient may not need radioactive iodine ablation. How to manage? Actually, primary management, and this is the same as follicular thyroid cancer. This is the treatment of differential thyroid carcinoma, follicular papillary. Surgery is the first modality for treatment, followed by suppressive therapy in most patients, and followed by radioactive iodine ablation or radioiodine remnant ablation in high risk and selected intermediate risk patients. Thyroid lobectomy is recommended for patients with unifocal papillary microcarcinoma and no other risk factor. A total thyroidectomy is recommended if the tumor size more than 4 centimeter or a tumor of any size in association with any of the following criteria: multifocal, bilateral disease, extrathyroidal spread, familial disease, and those with clinically or radiologically involved node or distant metastasis. So if a tumor size is more than 4 centimeter, this is a need a total thyroidectomy, or any size with this condition. Yes?
Dr. Khalid, we are discussing the management of papillary thyroid. Papillary.
Yes, they mainly for papillary, and the same management for follicular. The treatment of papillary is the same as follicular thyroid cancer.
Okay.
So this is the management of differential thyroid cancer. The primary treatment is surgery, followed by suppressive therapy in most patients, followed by radioactive iodine remnant ablation in high-risk patient and in selected intermediate risk patient, not for low-risk patient. So if the size is less than 2 centimeter and not associated with the following condition, we can do thyroid lobectomy. But if the size is more than 4 centimeter, we should go to the total thyroidectomy. And actually, in a previous exam, they asked a question about how to manage papillary or follicular thyroid carcinoma, and usually the first choice is total thyroidectomy. A central compartment neck dissection is not recommended for patients without clinical or radiological evidence of lymph node involvement, especially in the patient less than 45 years, unifocal tumor less than 4 centimeter, and no extrathyroidal extension. But if patient presented by follicular cancer more than 4 centimeter appears to have a worse prognosis and should be treated with a total thyroidectomy. Actually, in any thyroid cancer more than 4 centimeter, I will go to total thyroidectomy. A clinically evident cervical lymph node metastasis is best treated with radical modified neck dissection with the preservation of sternocleidomastoid muscle, spinal accessory nerve, and internal jugular vein. And actually, this is a sophisticated steps in the management. And actually, but just we can know a hint about it. Adjuvant therapy, radioiodine therapy, and actually I will discuss this in more details in the next session, inshallah, in the next Friday with British Thyroid Association guidelines about thyroid cancer. But we should know that radioiodine is administered after thyroidectomy orally in patients with differentiated thyroid cancer. And don't forget that this is not DIC, it is a differentiated thyroid cancer, DTC. To ablate residual normal thyroid tissue, which is known as radioiodine remnant ablation, or RRA, radioiodine remnant ablation. The decision to treat with radioiodine depends upon the risk of recurrence and persistent disease. The radioiodine is usually administered after total thyroidectomy in high-risk patients and in selected intermediate-risk patients, depending on specific tumor criteria like microscopic invasion into the parathyroidal soft tissue, clinical significant lymph node metastasis outside thyroid bed, or other higher risk factor. In the absence of proven benefits, I don't know what is the problem in my voice, but I hope it is clear now. So, a radioiodine ablation is not routinely administered in patients with low-risk disease, especially if unifocal tumor less than 1 centimeter, without other high-risk factors. Even in the presence of small volume regional lymph node metastasis less than 5 lymph node measuring less than 2 millimeter, we cannot give a radioiodine ablation. Whole body scan, WBS, means whole body scan, done 4 to 6 months after administration of high dosage of radioactive iodine ablation. A small dosage of radioactive iodine ablation, it is just 150 megabecquerel. Radioactive iodine ablation to scan the body to help to determine the presence of any residual disease. So, the whole body scan is done 4 to 6 months after thyroidectomy. How to do a whole body scan after administration of a small dose of radioactive iodine 131 to determine the presence of any residual disease. But a high dosage of radioactive iodine like 1.1 gigabecquerel or 3.7 gigabecquerel, this is a therapeutic dose. But this is a small dose, is a diagnostic dose. So we do whole body scan by a diagnostic dose, but this is a therapeutic dose or radioiodine ablation therapy. In the presence of metastasis, we give a very high dose of radioiodine, which is used in a very high dose to ablate metastatic cells. Recombinant TSH, or what is known as Thyrogen. Thyrogen is a very expensive drug. This is an alternative to liothyronine cessation. And actually, I will discuss this point to clarify it in the next slide and inshallah in the next presentation. Actually, before giving a radioiodine ablative therapy, we should stop thyroxine. We should elevate TSH more than 30 to render radioactive iodine effective. How to bring TSH in hypothyroid stage, TSH more than 30? In this situation, we have 3 options. One of them is stopping levothyroxine for 4 weeks. Another one, if the patient on liothyronine, we should stop liothyronine before the dosage by 2 weeks. And the alternative, it is by giving recombinant TSH without stopping liothyronine or levothyroxine. Liothyronine is administered for 4 to 6 weeks in place of levothyroxine and then omitted for 10 days or 2 weeks prior to the scan, allowing TSH to rise more than 30. And we should put our patient in low iodine diet for 2 weeks before therapy. This will increase the effectiveness of radioactive iodine ablation. And of course, the patient should be isolated until residual dose meter reading less than 30 megabecquerel. A very important topic is stimulation, and liothyronine is drug is cytomel. Recombinant TSH is Thyrogen. Post-ablative scan can be done and stimulated TG and neck ultrasonography should be performed in the presence of diagnostic whole body scan between 9 and 11 months from radioiodine ablation therapy. And this is 3 different protocols for preparation of our patient for radioiodine remnant ablation therapy. The first option, if the patient done total thyroidectomy more than 4 weeks before radioactive radioiodine remnant ablation, in this situation, the patient already in levothyroxine before remnant ablation by 4 weeks, we should stop levothyroxine and give liothyronine, which is cytomel T3, until 2 weeks before radioiodine remnant ablation. So I will stop cytomel 14 days before the day of radio. So the first option of a preparation for remnant radioiodine remnant ablation, if the operation is done more than 4 weeks before ablation, the patient already in levothyroxine, we should stop levothyroxine for weeks before intervention, and the patient will be take liothyronine because liothyronine has a small shorter half-life than levothyroxine, so we can stop it 2 weeks before radioiodine remnant ablation, and in the 2 weeks before remnant ablation, we should put our patient in low iodine diet, and the patient will receive radio remnant ablation after stopping cytomel by 2 weeks. Another option, if the patient already done the operation before less than 4 weeks before radioiodine remnant ablation, in this situation, the patient can receive cytomel immediately after operation, liothyronine, and we should stop it 2 weeks before remnant ablation, and also the patient should be put in low iodine diet 1 to 2 weeks before radioiodine remnant ablation. The third one, which is more expensive actually, by using Thyrogen, which is recombinant TSH. In this situation, the patient already in levothyroxine, and 2 weeks before remnant ablation, the patient should be put in low iodine diet, and we will give 2 shots of Thyrogen, one of them 2 days and another 1 day before radioiodine remnant ablation to bring TSH more than 30. And actually this algorithm I will discuss it another time in the next session, inshallah, from British Thyroid Association Guidelines 2014. And actually in this algorithm, this is not correct one. Levothyroxine should be continued until not stopped. So this arrow is wrong in the guide. This arrow is wrong. So levothyroxine can be continued, should be continued until radioactive radioiodine remnant ablation, and we give a Thyrogen to bring TSH more than 30, so radioiodine remnant ablation is effective. So this arrow is not correct in this guideline.
Dr. Khalid, I didn't get this.
Yes.
methods.
Yes.
These methods. I didn't get these methods.
The voice is not clear, Dr. Mahawish.
Sir, I didn't get these methods.
Yes.
Will you repeat?
Which one? All of these? I will
Yes.
repeat it in the next session, inshallah, because this is slide
Okay.
from the British Thyroid Association guideline. So, for preparation for radioactive remnant ablation or whole body scan, we have three options. The first one is to giving levothyroxine, and we should stop it 1 month before radioactive remnant ablation, and giving cytomel, which is liocyanine, which is a shorter half-life, so we can stop it 2 weeks before radioactive remnant ablation, and the patient put in low iodine diet in this period, and this stopping of liocyanine and levothyroxine will bring TSH more than 30, so remnant ablation will be effective. Another option is to giving liocyanine alone. If the patient already done a total thyroidectomy within less than 4 weeks before radioactive remnant ablation, in this situation, I will stop liocyanine 2 weeks before remnant ablation. Another one is by giving levothyroxine until and continuous use of levothyroxine till remnant ablation. Actually, we will not stop levothyroxine in this situation, and to bring TSH elevated more than 30, we will give a Thyrogen, which is a very expensive drug. Actually, it's a 2 shots, 1 shot 2 days before a remnant ablation, and another 1 shot 1 day before a remnant ablation. And actually, as I mentioned, this arrow is not correct in the guideline. This arrow is not correct, so it is written. It is a mistake in this guideline. What is if TSH is not more than 30? Actually, if we stop liocyanine for 2 weeks, it must be more than 30. Liocyanine half-life is short, and the levothyroxine, once we stop levothyroxine more than 4 weeks, TSH must be elevated more than 30. And actually, in some situations, and I will actually discuss it later on in the next session, inshallah. For example, if the patient have some sort of central hypothyroidism, even if the patient presented by medullary differential thyroid carcinoma, and we do total thyroidectomy, TSH will not be elevated. In this situation, Thyrogen usage is mandatory. So in some situation in which TSH is not elevated, if we stop levothyroxine or liocyanine, in this situation, this mandatory use of Thyrogen to increase TSH to more than 30, and this is specifically in a patient with central hypothyroidism. Or in another situation, if the patient already in levothyroxine or liocyanine, and we cannot stop this drug because the patient morbidity may be affected. If the patient, for example, if we stop levothyroxine, will presented by severe heart failure, in this situation we cannot stop levothyroxine. In this situation, we should use Thyrogen to elevate TSH more than 30.
So we will have to use Thyrogen to raise the TSH.
I will present the protocol of giving Thyrogen, and actually I think in this presentation, I will put I think this protocol will be presented, I think, in this presentation or next presentation. Actually in this presentation. So I will present how to give a Thyrogen after a few slides from a very important paper. Actually, I extracted some important algorithm to focus and to give some of highlight about this important topic.
Okay.
Clinically, according to Dr. Najah, what is the best option clinically according to actually resources? The most important, the most effective, and the most if you have a money is the third option by using Thyrogen. But actually Thyrogen is very expensive. In our locality, Thyrogen is more than 10,000 Egyptian pound. Actually this is since 1 or 2 years. Actually today I think it is more than this. So Thyrogen is very expensive. If it is available, so this is the best protocol. But if not available, I think the option 1 is the best available one. And actual cytomel or liothyronine is not available in most of our localities, so we give levothyroxine, and we will stop levothyroxine for 4 weeks before giving radioactive remnant ablation. And in this duration, 4 weeks, if the patient is high risk, recurrence may be increased because levothyroxine is a suppressive drug which will suppress recurrence of thyroid cancer. So stopping of levothyroxine can increase the morbidity of our patient. Adjuvant therapy, levothyroxine suppressive therapy is required in most patients to prevent hypothyroidism, and also a reduction of the serum TSH concentration to below the normal range decrease morbidity and morbidity in all patients with differentiated thyroid cancer, but this theory is not being proven 100%. So in patients with low risk disease treated with total thyroidectomy, an undetectable serum TG level, whether without remnant ablation or who were treated with lobectomy, serum TSH can be maintained between 0.5 and 2, lower half of the normal. So in a patient, this is the target of the TSH in a low risk disease, in a low risk patient. So in this situation, thyroid hormone treatment may be unnecessary if the serum TSH is maintained in this range post lobectomy. So in some patients presented with papillary carcinoma and treated by lobectomy, hemithyroidectomy, and the TSH is in the lower half of the normal without thyroxine therapy, and the patient is low risk. In this situation, the patient can go home without replacement therapy because the target of the TSH is less than 2. For a patient with intermediate risk disease, the serum TSH target needed to be 0.1 to 0.5, mildly lower than normal. But in the high risk disease, serum TSH should be less than 0.1. So the target of the TSH in the patient with differentiated thyroid cancer according to the risk stratification. In low risk, the target is lower in the lower half of the normal. In a high risk patient, the target is less than 0.1. In intermediate risk, the target of the TSH is 0.1 to 0.5. But in the exam, if you cannot be sure the risk stratification of your patient and they ask about the target of the TSH, please choose 0.1, less than 0.1. But if this is actually in the exam, if you cannot for life, Dr. Arado, how long it should be suppressed for life? And actually the target of the TSH suppression during pregnancy is the same as non-pregnant female. So actually in any patient presented to your clinic with low TSH and mentions that he do total thyroidectomy, please check, because if he do total thyroidectomy because differentiated thyroid carcinoma, TSH must be lower than 0.1 in high risk group. But don't forget that we should assess overly aggressive levothyroxine therapy because the overdosage of levothyroxine for long duration can accelerate the bone loss, LAF, and cardiac dysfunction. So we should maintain TSH as this target as possible.
سؤال بعد اذنك يا دكتور خالد.
Yes.
If we reach this target by giving levothyroxine without aggressive levothyroxine and reach the target of TSH of 0.1, clinically, this patient don't have hyperthyroid manifestations?
Actually, no. Most cases, no. But actually, if the patient presented by some symptoms hyperthyroidism, we can just use some sort of beta blocker in this situation. But actually, this target is the only method to decrease the recurrence of thyroid cancer. And this actually according to the risk stratification. If the patient is low risk, no, so in this situation the target will be no low normal, lower half of the normal. But in the high risk group, we should bring TSH to be less than 0.1, but not undetectable TSH. Because if the TSH is, for example, 0.01, in this situation, we can decrease the dose of levothyroxine to bring it just lower than 0.1 only.
Dr. Khaled, just I wanted to ask, according to guidelines, low-risk disease patients, they need to have lobectomy. But who will be, what do you call it, a candidate for thyroidectomy?
If the tumor size is more than 4 centimeters, this is must be do total thyroidectomy. But if tumor size is less than 2 centimeters without metastasis or without lymph node, in this situation we can go to lobectomy. But actually in clinical practice, once you see a case of papillary thyroid carcinoma, please go to the total thyroidectomy. Actually, lobectomy is important in localities in which the follow-up is restricted. But in some of our, in most of our countries, if the patient doing lobectomy, he will miss the follow-up. And in this situation, a recurrence may be increased. So if you can have a 100% of the follow-up, your patient will follow up you regularly, in this situation we can go to lobectomy. But actually in clinical practice, in our clinical practice, total thyroidectomy is the best option.
Thank you.
And of course, for microcarcinoma, lobectomy is the best option. Even in if you diagnose a papillary microcarcinoma, active surveillance can be sufficient according to the most of the guidelines. Actually, so if you diagnose a papillary microcarcinoma, and in this situation, lobectomy versus active surveillance is a good option, according to the American recommendation and also European recommendation, updated European recommendation. Thyroglobulin is a very sensitive marker of recurrence of thyroid cancer. Please don't choose doing thyroglobulin in any patient except if you suspect factitious thyrotoxicosis. In this situation, thyroglobulin is very important because it will be suppressed. And another situation you order thyroglobulin is following patient with differentiated thyroid cancer. After doing a total thyroidectomy and radioactive iodine ablation, thyroglobulin must be near zero. The level of the TG should be less than 0.27 microgram per liter. Once the TG increase, this denotes a recurrence of thyroid cancer. Measurement of thyroglobulin level could be made difficult if there is TG antibody. TG antibody will interfere with assay of the TG, leading to the false low TG. If TG antibody is positive, in this situation, TG assay will be falsely low. So, in each time you ask about TG, please do TG antibody. If TG antibody is positive, in this situation, if TG is low, this may be false low result and thyroid recurrence may be presented. But if TG antibody is negative, TG is accurate method for follow-up of a patient with differentiated thyroid carcinoma. And of course, the coming of thyroid hormone or giving recombinant TSH increase the sensitivity of TG. This is stimulated TG by recombinant TSH, and I will discuss it after a few slides. This is a question from a toolbook. This is a 50-year-old woman reviewed for in the thyroid cancer clinic or routine follow-up. The patient undergone a total thyroidectomy followed by radioactive iodine ablation for a well-differentiated 2.5 centimeter follicular thyroid cancer. No node and no distant metastasis N0, M0, which no node and no distant metastasis since 3 years previously. Nowadays, the 3T4 is mildly elevated, TSH is low, suppressed 0.04. The TG is detectable TG. Once you see TG, you should look for TG antibody. TG antibody is negative, so TG means recurrence. Once TG is detectable, this means maybe a recurrence of thyroid cancer. Radioactive iodine scan is negative. Which one of the following is the most appropriate further management approach in her case?
PET scan?
PET scan.
Ultrasound of the neck.
Yes, yes. So, ultrasound and the question of Dr. Barakat asked if the patient is TG antibody positive, how we will follow up clinically and by sonography. So, if TG antibody is positive, in this situation, if TG is elevated, so this means a recurrence. But if TG is low, this may be due to the interference of TG antibody. So, we should follow clinically and by sonography. So, in this situation, if you suspect recurrence, what is the best method for assessment of recurrence? By doing thyroid sonography. So, thyroid sonography is the best modality for assessment of recurrence. And actually, this is from a toolbook, and actually, this is from British Thyroid Association guidelines for TG measurement in patients with differentiated thyroid cancer. To ensure continuity in monitoring, clinicians should use the same laboratory and TG assay on the long-term basis. In each time, you should do TG assay in the same lab. TSH and TG antibody should be measured simultaneously with the serum TG. For patient in remission, please measure TG and TSH on annual basis. No need for TSH stimulation if the basal serum TG is already detectable. This situation, but if TG is not detectable, in this situation we can stimulate TG. In the presence of rising TG level, there are 3 appropriate options like our case. The first one, no action until the patient is symptomatic. The second one, empirical use of radioactive iodine therapy. And the lastly, investigate to localize disease recurrence. How to localize, investigate for recurrence of the disease? The first one, by doing thyroid sonography. If it is normal, CT scan. If it is normal, bone scan. If it is normal, PET scan. Please choose this option by this order. Because in some exam, or for example in the previous exam, they mentioned PET scan, for example. So, the PET scan is the last option. If neck sonography, CT, bone scan are normal, in this situation, I will go to PET scan if there is a high suspicion of recurrence. So, in this situation, I will do thyroid sonography. If it is normal, so there is no recurrence. But if there is a high suspicious risk of recurrence, for example, if TG is elevated or recurrence of TG antibody is elevated, in this situation, I will go to CT scan of the lung. If neck sonography is normal. If CT of the lung is normal, in this situation, I will do technician bone scan. If it is normal, I will go to PET scan. May be used if all the previous mentioned investigation are normal. So this order is very important. Yes, Dr. Saadiyya, CT lung to detect the lung metastasis, because the risk of metastasis is very high. Actually, not very high, but the risk of metastasis is high. In practice, how often should the TG and anti-TG be checked? I will go to this, Dr. Sana. After a few slides, I put algorithm when doing TG and anti-TG and how to do it. But actually, in most of our cases, at least in the first few years, we should do it annually. I will go to this slide immediately after 2 slides, Dr. Sana. What does detectable mean in the numbers? Elevated, more than a reference range, more than an undetectable limit. Once a TG is detectable, this is elevated TG. Actually, after total thyroidectomy, after radioactive remnant ablation, TG must be near 0 or undetectable. Once it is detectable, this means a recurrence or a risk of recurrence is elevated. If ultrasonography is negative, the second choice we will do CT scan, Dr. Radwa, if there is a high suspicion of recurrence. If CT scan of the lung is normal, I will go to the bone scan to detect metastasis to the bone. If the bone scan is negative, I will go to the PET scan if the risk of recurrence is elevated. What is the criteria for doing PET scan? I don't understand your question, Dr. Chavan. Once the patient have a high risk of recurrence with elevated TG, with normal thyroid sonography and CT and bone scan, I will go to the PET scan. A recurrent disease and distant metastasis patients are followed up with a TG level. After effective treatment, TG level are undetectable. Once there is a trend of increased TG value, should be investigated with radioiodine uptake scan or whole body scan. The principal indication for diagnostic whole body scan after radioactive iodine in cases where measurement of serum TG is unreliable due to, for example, a presence of anti-TG. In this situation, radioiodine uptake was visualized beyond the thyroid bed. In the case of recurrence, treatment employs all methods used in the primary and adjuvant therapy for surgery or radioactive iodine ablation and suppressive therapy. When should we do it? The last option is PET scan, Dr. Chavan. The last option for detection of the recurrence is PET scan. External radioiodine therapy is indicated in non-resectable tumor that does not take radioactive iodine. So external radiotherapy may be used for treatment of metastasis if don't take radioactive iodine. Bone and pulmonary metastasis, usually osteolytic, may be treated with radioactive iodine, but very high dosage of radioactive iodine. About 50% of metastasis concentrate radioactive iodine, and so there is a kinase inhibitor drug that can be used for management of metastasis. One of these drugs is sorafenib and sunitinib, and another drugs that used for management of advanced metastatic differentiated thyroid carcinoma. مساء الخير دكتور محمد حميدة. And of course, this drug is advanced drug. This is available nowadays for management of metastatic differentiated thyroid carcinoma, and this is a selective MABIC pathway antagonist. And the most important side effect of this drug is hypertension, renal toxicity, bleeding, myelosuppression, arterial thrombosis, cardiotoxicity, thyroid dysfunction, especially hypothyroidism, cutaneous toxicity, hand-foot skin reaction, delayed wound healing, hepatotoxicity, and muscle wasting. But of course, the benefits is more than this side effect, as the only available medical treatment for metastatic thyroid differentiated thyroid carcinoma. And also, these drugs are tumorostatic rather than tumoricidal. And this is what just a few paragraph about the Thyrogen. The Thyrogen, this is a recombinant TSH. And of course, if we stop thyroxine, the patient will go into hypothyroidism, which may affect morbidity and mortality due to the levothyroxine withdrawal. In this situation, we can use Thyrogen. Also, Thyrogen must be used if the patient presented by TSH deficiency like hypopituitarism and thyroid carcinoma. In this situation, to elevate TSH, we should use Thyrogen. How to give Thyrogen? Dosage of it, we will give it 0.9 milligram of recombinant TSH on the day 1 and day 2, and measure TG on the day 5, actually after 96 hours. For serum TG testing, serum TG should be obtained 72 hours after final injection of recombinant TSH, and I will cover it in a diagram. So this, I have 2 questions from the toolbook, and I will cover it again in the Thyrogen. A 25-year-old woman was incidentally detected to have a thyroid nodule less than 1 centimeter, 0.8 centimeter, on thyroid sonography. No previous history of neck radiation, and no family history of thyroid-related malignancy, no visible or palpable goiter or cervical lymph node. F34 is normal, TSH is normal. Which one of the following is the most appropriate management approach in her case? Manage in primary care, measure calcitonin, measure thyroglobulin, non-urgent referral to fine needle aspiration cytology, urgent referral to fine needle aspiration cytology.
Manage in primary care or
manage in
non-urgent
primary
referral for
care.
malignancy? A
What
or D?
about non-urgent referral to fine needle aspiration cytology?
Less than 1 centimeter, no need.
As there is no risk factor in this situation, I will manage in primary care. And actually, this is a table, this table from the guideline, British Thyroid Association guideline. When to manage in primary care if there is a thyroid lump or goiter which remain unchanged in the size, non-palpable thyroid nodule less than 1 centimeter. Non-urgent referral if there is abnormal thyroid function test, if there is sudden onset of the pain in the thyroid lump, if gradually enlarging over months thyroid nodule. In urgent referral, unexplained hoarseness or cervical lymph node, thyroid nodule in the children, or rapidly enlarging thyroid nodule. Same day referral if there is stridor. So this table is very important. Yes, Dr. Muhammad, it is managed in primary care. Follicular thyroid carcinoma, this is a neoplasia. This is the second most common thyroid cancer after papillary thyroid cancer. It may show capsular or vascular invasion. Surgery is usually necessary for follicular adenoma, but to differentiate, is it adenoma or carcinoma? Follicular thyroid carcinoma may be minimal or widely invasive. Metastasis is about 20% of the cases, usually hematogenous metastasis. Lung, elbow, and the bone metastasis is the most common size, less likely to local lymph node metastasis. And actually, in some exams, they ask a question about follicular thyroid carcinoma and how to treat, actually the same as papillary. Hurthle cell carcinoma, this is a poor prognosis variant of follicular thyroid carcinoma, and it fails to concentrate radioactive iodine therapy. The same presentation as follicular thyroid carcinoma, usually asymptomatic thyroid nodule. This is the Hurthle cell carcinoma, usually asymptomatic thyroid nodule in the older patient, and similar pattern of distant metastasis, lung, bone, brain. Hurthle cell carcinoma metastatic foci are often radioactive iodine refractory, so should be treated only by surgery and suppressive therapy. About 20 to 30% of patients with Hurthle cell carcinoma have metastatic extension at the same time of initial treatment, so radiotherapy can be used. And also, this drug can be used for management of Hurthle cell tumor. How to treat? The same as papillary thyroid carcinoma. as papillary thyroid carcinoma. Total thyroid, this is a for follicular thyroid carcinoma. Total thyroidectomy, suppressive therapy, radioactive iodine according to the risk stratification of the patient. How to follow up? This is very important for differentiated thyroid carcinoma. The follow up is lifelong. The recurrence occur at least to 25 years, so lifelong follow-up is mandatory. Follow-up usually involve annual clinical review with the clinical examination of the presence of suspicious lymph node and measurement of the serum TSH to ensure the target level and TG. So we should doing TG and TSH annually. Serum TG should be undetectable in patient with total thyroid ablation. Once detectable level may be seen up to 6 months after thyroid ablation, this is usually normal variant. Detectable level may be presented up to 6 months after thyroid ablation. A trend of increasing TG level requires investigation with radioactive iodine scan or whole body scan. We should stopping thyroid hormone or using Thyrogen. And another imaging modality like sonography or CT scan or bone scan must be an option. TG antibody, as I mentioned, must be checked each time we doing TG assessment. Detectable TG and absent uptake on radioiodine uptake scan may be due to the de-differentiation of the tumor and failure to take up iodine, like as I mentioned, Hurthle cell carcinoma. In patients with serum TG more than 10 nanogram per milli and negative radioiodine scan, I will go to PET scan. PET scan may be required. Metastatic lesion with high avidity for glucose in the PET imaging necessitate assessment of this thyroid nodule because the risk of malignancy is about 20%. And this question, which one of the following is a marker of poor prognosis in patient with differentiated thyroid cancer? Age 20 to 40, female gender, Hashimoto's thyroiditis, tumor size, well-differentiated tumor. Which is a marker of poor prognosis? Which one?
Tumor size.
Age or tumor size or well-differentiated tumor? Or female gender?
Tumor size.
Yes, Dr.
Tumor
Asana.
size, yes.
Yes. Tumor size, as I mentioned the previous a lot of time, tumor size is one of the markers for poor prognosis. Once a tumor size is more than 4 centimeters, this is a bad prognosis. So this is a marker for poor prognosis. Age is less than 10 or more than 40. Male gender is a poor prognosis. Cellular differentiation and vascular invasion, tumor size and tumor lymph node or metastasis is a risk factor for poor prognosis. And actually, this algorithm and the following two slides, I capture it from this important paper published in, I think, European Journal of Endocrinology, a paper published, I think, since 2 to 3 years, the role of recombinant TSH in the management of differentiated thyroid cancer, pros and cons. And actually, this is a protocol for giving recombinant human TSH testing or Thyrogen. Actually, we give Thyrogen, the first dosage. Before giving it, I will measure TG and TSH. And the second dosage after 24 hours. And if we give, in this situation, I will check for whole body scan or radioiodine scan after 48 hours. And if we give a diagnostic dosage of radioactive iodine, I will give it after 48 hours from the first Thyrogen injection. At the day 3, start of the day 3. The whole body scan, if we do whole body scan, we will do it on the day 5. Also, we will assess TG measurement on the day 5. So, thyroglobulin is determined on the day 5. Radioiodine used for treatment, this one is done in day 3 or 2 days after the first dosage. And this is used for treatment, and also we can give a diagnostic radioiodine also in the day 3. If we're doing whole body scan or TG, we will do it in day 5. How to follow up of patient with differential thyroid carcinoma from the same paper according to our risk stratification. So this algorithm is very important for following our patient of differential thyroid cancer after doing thyroidectomy. Regarding a low to intermediate risk patient, the patient should be on thyroxine. I will not stop thyroxine. I will give him Thyrogen in the day 1 and 2, and in the day 3 they mentioned that we will blood sampling for TG measurement and radioactive iodine administration. This is the first one. And after 6 to 12 days, a negative post-treatment radioactive iodine whole body scan. This is immediately after treatment, after thyroidectomy. The first follow-up will be done after 6 to 12 months. The patient already on levothyroxine, and I will do thyroglobulin and neck sonography. Thyroglobulin and neck sonography. High sensitive thyroglobulin assay. If high sensitive thyroglobulin is less than 0.1 with negative thyroid sonography, in this situation, the follow-up will be every 1 to 2 years by clinical examination and just doing thyroglobulin on levothyroxine. The patient already on levothyroxine. And actually, each time you do high sensitive thyroglobulin, you should do TG antibody. If a TG antibody or neck sonography are positive sonography or any TG value, we should work up and reevaluate and reassess the treatment of recurrence. If a TG is elevated with negative sonography, in this situation, I should monitor TG trend and I will do stimulated TG. And if a TG stimulated TG is elevated, in this situation, this is a recurrence, I will manage according to the recurrence protocol. But in high risk group, in this situation, I should stop levothyroxine as a first option and assess TG and radioactive iodine ablation. And after 6 to 12 days, negative post-treatment radioactive iodine whole body scan, I will follow up after 6 to 12 months by doing neck sonography, TG testing, and whole body scan. So, whole body scan is mandatory if the patient is high risk differential thyroid cancer. If undetectable TG with negative thyroid sonography and negative whole body scan, in this situation, I will follow up my patient every year by clinical examination, neck sonography, and the TG. So, in a previous, no sonography in the follow-up if the first TG and sonography are negative. But in high-risk patient, sonography is mandatory every year, clinical examination and the TG is mandatory. If positive sonography or whole body scan or any TG value, I should work up and reevaluate for recurrence. But if TG is elevated with negative sonography and whole body scan, in this situation, I will monitor TG trend and I will repeat TSH and whole body scan. And if TG is more than 10, I will work up and reevaluate for treatment. Thyroid cancer and pregnancy is actually not different than non-pregnant one, but don't forget that surgery is if done in the second trimester, and radioactive iodine is contraindicated either scanning or therapeutic. And actually, if we cannot operate a pregnant female with operation, we should give a suppressive dose of levothyroxine. So, lesion less than 2 cm in diameter or any lesion appearing after 24 weeks gestational should be treated with a suppressive dose of levothyroxine. And after re-evaluation postpartum. Operation should be performed at earlier safe opportunity, either during the second trimester or immediately postpartum. Pregnancy must be excluded before radioactive iodine therapy. Breastfeeding must be discontinued at least 2 months before radioactive iodine therapy to avoid the breast irradiation, and should not be resumed until after subsequent pregnancy. The pregnancy should be avoided after 6 months after radioactive iodine ablation. And actually, this is a very important and usually question in the exam. Thyroid cancer in children is also is rare. It is uncommon condition, but actually risk of malignancy is high in children. Most of cases are papillary thyroid carcinoma, about 85%, and also it is a more aggressive behavior. And actually, we should red oncogene rearrangement are common in this tumor after Chernobyl and nuclear accident in Ukraine and Belarus. And actually, risk of malignancy is increased in children, usually papillary thyroid carcinoma. And the management is the same as adults. That the American Thyroid Association published a very important guidelines about the thyroid nodule and cancer in children in 2015. And also lifelong follow-up is recommended with measurement of serum TG as adults. Yes? Yes, I am with you.
Dr. Khaled?
Dr. Alain. Yes? The voice I did not let
Case pregnant patient. Okay.
The voice is interrupted. Your voice isn't. I didn't hear your voice.
Now it's clear?
Yes, yes.
Okay, Dr. Khaled, now I have patient pregnant, okay, newly discovered hypothyroid, okay.
Yes.
By ultrasound, the patient multinodular goiter and the pressure symptoms. Then a patient now pregnant 10 weeks. So thyroidectomy, how to proceed to thyroidectomy, especially in the patient the first trimester. And the patient really have severe pressure symptoms.
Actually, if severe pressure symptom, I recommend the surgery actually, and in this situation, I will recommend medical abortion. So I think life saving of the mother is better than saving the fetus. So this is an emergency condition, and you will go once compression severe compression symptoms, go to the surgery irrespective of the gestational age. This is a life-saving condition for the mother.
Okay. Okay, Dr. Khatab, for my endocrinologist on how to deal with case, I refer just to the surgeon to thyroidectomy?
Yes, yes.
Oh, okay, Dr. Khaled. Okay, thank you.
And of course, rendering the patient euthyroid because the patient is hypothyroid. Just a replacement therapy by levothyroxine and refer for the surgery.
Okay, Dr. Khaled, thank you.
Okay. So we go to the medullary thyroid carcinoma. We cover differential thyroid carcinoma, papillary and follicular. Medullary thyroid carcinoma, inshallah, we will discuss it in more details with multiple endocrine neoplasia type 2 in a separate chapter. And medullary thyroid carcinoma accounts about 5 to 10% of all thyroid cancer. It is rare but aggressive. It can be cured only if intrathyroidal at diagnosis. About 75% sporadic, 25 are familiar, and the two forms are distinguished by red mutation analysis. Calcitonin is the specific serum tumor marker. It is doubling time is the most important prognostic factor for survival and prognosis. And actually, in the in our previous exam, they ask usually this is a very important family history of thyroid cancer contraindicate to receive liraglutide. Liraglutide is a very important GLP-1 receptor agonist drug used for management of diabetes, and with liraglutide, risk of medullary thyroid cancer is increased, and actually this is trials increase in rats, not in a human. But actually, if a patient have a family or history of medullary thyroid carcinoma, liraglutide is a contraindicated, and this is a very important liraglutide, which is available as Victoza. So liraglutide is contraindicated if a patient has a family history or a previous history of medullary thyroid carcinoma. The presentation of medullary thyroid carcinoma, lump in the neck, and systemic effect of calcitonin in the form of flushing and diarrhea. How to diagnose? By doing final aspiration cytology and also comprehensive family history and screening search in a case of men type 2A or B. Because in a patient presented by men 2 or B, we should screen for medullary thyroid carcinoma and doing surgical conservative surgery before age of 5 or age of 1 year in medullary 2A or 2B. الباثولوجي specimen show immune staining for calcitonin and staining for amyloid. How to manage? Of course, we should have a baseline plasma calcitonin, baseline biochemical investigation for pheochromocytoma if you suspect men, pheochromocytoma and hyperparathyroidism, and genetic screening with red mutation analysis, and also staging with thoracoabdominal CT or MRI, and we can do MIPIG scan in some cases. How to treat medullary thyroid carcinoma? Total thyroidectomy and central node dissection is the first line of treatment. Germline red mutation carrier should ideally undergo thyroidectomy before age of 5 years of age. So red mutation gene analysis is very important, because once it is presented, even if the patient is not presented by medullary thyroid carcinoma, we should do conservative thyroidectomy before age of 5. Another treatment modality for medullary thyroid carcinoma is radioiodine. Radioiodine is not used for management of medullary thyroid carcinoma. This is very important. TSH suppression is not used for medullary thyroid carcinoma. So radioiodine and TSH suppressive therapy is unique for differentiate thyroid carcinoma only. In a patient of medullary thyroid carcinoma, we give thyroxine as a replacement therapy, not suppressive therapy. The third radiotherapy have a little benefits. 30% of medullary thyroid carcinoma have a distant metastasis at diagnosis. So some drugs can be considered like fanditinib and cabozantinib. The follow-up or also lifelong follow-up is mandatory in a case of medullary thyroid carcinoma. Anaplastic thyroid carcinoma, this is a rare condition. The peak incidence 7th decade, more common in the female, more common in the male. Anaplastic thyroid cancer more common in the male, characterized by rapid growth of a firm, hard, fixed tumor, often infiltrate local tissue, does not move on swallowing, aggressive, poor long-term prognosis, 7% 5-year survival rate, mean survival of 6 months from a diagnosis. How to treat anaplastic thyroid cancer? By total thyroidectomy, but usually impossible. So external radiation and chemotherapy is the best next options. And actually, this is a question in a previous exam. They ask about the management of anaplastic thyroid cancer. How to manage total thyroidectomy. If total thyroidectomy cannot be performed because the tumor near some of vital organs, external irradiation and chemotherapy can be alternative for the surgery. And also a BRAF, this is a BRAF mutated gene is important in anaplastic cancer. Another drugs, medical combination therapy, dabrafenib and trametinib, and another ifrolizumab, another promising drugs that may be used as alternation in this situation. In lymphoma, and actually this is the last cancer in thyroid. This is uncommon, almost always associated with amiodarone-induced thyroid, not amiodarone, autoimmune thyroid disease, AITD, autoimmune thyroid disease, especially Hashimoto's thyroiditis. Risk of lymphoma is increased 70-fold than in non-Hashimoto's. More commonly in the female and in patient age more than 40 years. This is characterized by rapid enlargement of the thyroid gland, usually non-Hodgkin lymphoma, and treated by radiotherapy, and in some situation combination radio and chemotherapy, which is often produce a good result. And this actually is a question in our previous exam in 2016. How to treat lymphoma, usually radiotherapy and chemotherapy. Surgery is not used in management of lymphoma. So this is the last slide in the cancer, thyroid cancer, and actually I will cover some of important suggestion, and this is a unique in the 4th edition of the Oxford Handbook, and this actually suggestions cover different parts rather than thyroid. This is one. The first suggestion: avoid indiscriminate ultrasound imaging of the thyroid. Thyroid cancer are rare with annual risk, and we should refer urgent referral if there is a thyroid nodule in a young or elderly. We should refer within 2 weeks if recent increase in size of thyroid nodule or obstructive symptom or voice change or associated lymphadenopathy. Another suggestion: hyperthyroidism is not a diagnosis. It is important to establish the etiology of hyperthyroidism. Hyperthyroidism may be due to the grave disease which need to be managed medically or radioactive iodine or surgery, toxic adenoma or toxic nodule which need to be managed medically by surgery or radioactive iodine. Radioactive iodine is the first choice for toxic adenoma. Surgery may be used in medical therapy as a transient period to rendering your patient euthyroid, but in some other cases or causes of hyperthyroidism may be amiodarone or lithium or thyroiditis, viral or silent autoimmune thyroiditis. So the etiology is mandatory before managing of any case of hyperthyroidism. The presence of TSH receptor antibody is pathognomonic for a grave disease. Positive TPO antibody indicate autoimmune thyroid disease, not pathognomonic for any disease. Management of subclinical hyperthyroidism: in a lot of scenarios, wait and see is ideal approach in the management of subclinical hyperthyroidism, especially if serum TSH is between 0.1 and 0.4, mildly low TSH. This is a grade 1 subclinical hyperthyroidism. In this situation, wait and see can be the ideal option in the management of a grade 1 subclinical hyperthyroidism. The risk of progression to overt hyperthyroidism is negligible in stage 1, and there are no significant end-organ effects. We manage subclinical hyperthyroidism stage 1 if there is a cardiac problem, if there is osteoporosis, if there is symptom. In this situation, we can treat by small dosage of carbimazole if the patient is underlying grave disease. But wait and see is the most appropriate approach in this scenario, and just taking thyroid function test after 6 to 12 months. But if free T3 alone is raised, this is a T3 thyrotoxicosis and need treatment like overt hyperthyroidism. And this is very important issue, because a T3 thyrotoxicosis may be initial phase of a Graves' disease. Another important tips is side effects of cyanamide, and this actually we cover it several times. A granulocytosis is a potential fatal side effect, occurs in 0.1 to 0.5%, and actually in our previous exam they ask about a percentage of a granulocytosis in individuals, and this occurs very suddenly, abruptly. So a routine monitoring of a CBC is not recommended. Once the patient presented by fever, sore throat, or you suspect a case of a granulocytosis, you should stop antithyroid drug and doing leukocytic count, differential leukocytic count. If leukocytic neutrophil is less than 500, in this situation, this is a granulocytosis, you should treat by another modality, not propylseracil. In this situation, propylseracil also is a contraindicated. And this is usually occurs within the first 3 months of initiation of antithyroid drug. Once you suspect a granulocytosis, you should discontinue the drug and check blood count. The allergic type reaction, rash, urticaria, arthralgia occur more common than a granulocytosis, 1 to 5%, and are often mild and can be treated by antihistaminic drug. Case need to withdrawal of the drug. And allergic type reaction, we can constitute another alternative for carbimazole. If the patient already in the carbimazole, we can give propylseracil in this situation. Cyanamide in pregnancy, this is very important. The propylseracil is less teratogenic than in carbimazole. Propylseracil is used in a preconception period and in the first trimester. The carbimazole in the second and third trimester. Block and replacement therapy is not is a contraindicated in pregnancy. Definitive treatment of Graves' disease by radioiodine or surgery pre-pregnancy is ideal. So any female presented by Graves' disease and will be married in the next few months, I suggest doing surgery or radioactive iodine. Graves' orbitopathy may precede hyperthyroidism, and as we cover it in a separate session about the Graves' orbitopathy. But we should know that early symptoms of Graves' orbitopathy include redness, photophobia, lacrimation, swelling, redness, restriction of the eye movement, double or blurred vision, retroorbital pain, which is a lot of manifestation for clinically activity score. And don't forget that Graves' orbitopathy usually a clinical diagnosis. TSH receptor will typically be positive. Graves' orbitopathy is presenting about 50% of Graves' disease, about 25% evident clinically, and about 25%, another 25% by imaging modality. Severe and potentially sight-threatening in about 3 to 5%. Graves' orbitopathy may precede or follow the onset of hyperthyroidism, and also can be unilateral and may be presented in a patient with hypothyroidism. Stopping smoking, controlling thyroid dysfunction, selenium supplementation, eye lubricant are beneficial in mild cases. MRI should be considered if there is a diagnostic doubt and to assess whether glucocorticoids are required. Amiodarone thyrotoxicosis is a very important topic, and actually in most of cases we cannot differentiate between type 1 and type 2. In this situation, type 1 is managed by high dose of carbimazole, and type 2 managed by prednisolone. If we cannot differentiate between type 1 and type 2, I will give a high dose of carbimazole 40 mg with 40 mg of prednisolone for 2 weeks, followed by measurement of serum T3. If T3 reduction is more than 40%, in this situation, I will stop carbimazole and continue prednisolone, because this is amiodarone-induced thyrotoxicosis type 2. if no improvement, rapid improvement of T3, in this situation, I will stop prednisolone. Tapering of prednisolone, I will continue carbimazole because this is Amiodarone-induced thyrotoxicosis type 1. And this is a hint about treatment of subclinical hypothyroidism. I will treat subclinical hypothyroidism if TSH is more than 10, irrespective of the free T4, or if positive anti-TPO. And actually, another recommendation to treat if there is a symptoms, if there is another autoimmune disease, if there is pregnancy or infertility. In this situation, I will treat subclinical hypothyroidism. Levothyroxine in pregnancy in management, ideally, we will increase the dosage of levothyroxine. The target of the TSH is less than 2.5 prior to conception. And once the patient gets pregnant, we should increase the dosage of levothyroxine by 25 to 50 microgram daily in the first 4 to 8 weeks of pregnancy to maintain serum TSH between 0.5 and 2.5. Because fetus is completely reliant on maternal thyroid status until the second trimester, until maturation of hypothalamic pituitary thyroid fetal axis. So we will increase the dosage of levothyroxine by 25 to microgram as soon as the pregnancy is confirmed, or 25 to 50%. And actually, this is the last slide in our thyroid chapter, and so I will go to some of MCQs. So if anyone have any question about the thyroid, it is welcome before solving some of the questions.
السلام عليكم دكتور خالد.
وعليكم السلام ورحمة الله وبركاته.
دكتور نادر حسين معاك يا باشا.
يا هلا وسهلا دكتور نادر.
بارك الله فيك يا بيه، الله يكرمك. كنت عايز اسال سؤال بخصوص الليراجلوتايد من الجروب بتاع الجي بي 1 ريسبتور اجنوستيك، ده كونترا انديكيتد لوحده ولا هو كلاس افكت للمجموعه كلها في
No, actually the evidence about الليراجلوتايد alone, not all the group.
طب لو البيشنت بتاعنا have a negative history
and actually the risk of medullary thyroid carcinoma is just in experimental rats only increase the risk of medullary thyroid carcinoma, but this actually there is a black box warning in the liraglutide. If there is no family history, if no previous history of medullary thyroid carcinoma, liraglutide is one of the effective and anti-diabetic medication.
If no any suggestive history للmedullary cell carcinoma في البيشنت, is any work up needed before starting?
No. As regarding medullary thyroid carcinoma, risk no.
يعني فكرة الناس اللي بتيجي تعمل investigations قبل ما بتبدأ الجروب ده كلام clinical
No. For thyroid malignancy, no.
Okay.
No any prescription of liraglutide, no need for assessment of risk of medullary thyroid carcinoma before prescribing the liraglutide. But if the patient have a family history or previous history of medullary thyroid carcinoma, in this situation, liraglutide is a contraindicated.
Okay, doctor. Thank you. شكرا.
Excuse me, doctor.
Yes.
I think also dulaglutide also.
I don't.
And dula.
So I will check it, Dr. Najah. I can check it. Dulaglutide?
Yes, dulaglutide.
Just a minute. I will just. Dulaglutide. Actually, if you want to check this, I will go to the British BNF book and we can check it. Yes. Mhm. This is like this is from BNF. Important safety, serious life-threatening diabetic ketoacidosis, and actually this is pregnancy, patient care. I can search here from cancer. Actually, they did not mention that, but medullary thyroid cancer. The risk of medullary thyroid cancer with actually, this is just mentioned here. Dulaglutide injection may increase the risk that you will develop a tumor of thyroid gland, including medullary thyroid cancer. I can go to the medicine. But actually, in the medicine, dulaglutide is not here, but I can go to the dulaglutide in the medicine. I will go to the drug interaction. Yes, actually, in the Medscape, they mentioned that dulaglutide causes thyroid cell tumor in rodent. A human risk could not be determined. Contraindicated in patient with personal or family history of medullary thyroid cancer or in patient with MEN2. Dulaglutide is another GLP-1 receptor agonist. Is not can increase the risk of medullary thyroid cancer. So liraglutide and dulaglutide. And so this inshallah we will cover it in diabetes. So it is presented as a black box warning in the e-medicine. So I will go to some about 10 to 12 questions to finalize this session inshallah. Which one of the following is associated with increase the TBG level?
Tamoxifen.
Yes.
Tamoxifen.
So this is very important to know the disorders and the drugs that affected TBG. Drugs and condition increase TBG: pregnancy, oral contraceptive pills containing estrogen, tamoxifen, hepatitis A, chronic active hepatitis, biliary cirrhosis, acute porphyria, and also the conditions that decrease TBG: androgen, glucocorticoid, Cushing, chronic liver disease, severe systemic illness, active acromegaly, nephrotic, drugs like phenytoin. So this is a very important table. So a chronic active hepatitis increase TBG, but the chronic liver disease decrease TBG. So option D, chronic liver disease, will decrease TBG, but the chronic active hepatitis will increase TBG, and this is a very important conflicting point. Which one of the following condition is associated with decreased TG level?
Factitious. Thyrotoxicosis.
Factitious or untreated differentiated thyroid cancer?
Thyrotoxicosis
factitious.
Yes.
Factitious.
Any condition untreated differentiated thyroid cancer will be presented by normal TG, but thyrotoxicosis factitiata will presented by decreased TG. Another condition that differentiate between thyrotoxicosis factitiata and another etiological cause of thyrotoxicosis is radioactive iodine ablation. In a case of thyrotoxicosis factitiata, thyroid uptake will be low.
No.
This is a patient, 42-year-old woman, was reviewed in the multidisciplinary thyroid clinic, rapidly enlarging thyroid nodule, hoarseness of voice, family history of thyroid cancer, thyroid nodule 2.5 centimeter, non-palpable cervical lymph node, fine needle aspiration cytology papilla thyroid carcinoma, and the patient underwent elective total thyroidectomy, followed by radioactive iodine ablation. How soon after total thyroidectomy should TG level be measured?
After 1 year?
After
Annually?
6 weeks.
1
For
6 weeks
Follow
or
up.
6 months?
6 months.
6 weeks. 6 weeks, I think.
So don't forget that 6 weeks after total thyroidectomy, we can check TG not less than 6 weeks. But actually, practically, we detect TG after 6 months. But how soon after total thyroidectomy should TG level be measured? Regarding the British Thyroid Association guidelines, they recommend to do it after at least 6 weeks after surgery to avoid false positive results. But in clinical practice, we're doing TG after 6 months. An elective radioactive iodine ablation should be arranged within 3 to 6 weeks after thyroidectomy. Suppressive dose of thyroxine should be started 3 days after radioactive iodine ablation, keeping TSH level less than 0.1 in high risk group. Whole body scan with stimulated TG should be arranged after stopping thyroxine for at least 4 weeks after 9 to 12 months of radioactive iodine ablation if indicated. Whole body scan is only indicated in high risk group. And actually, we can stop thyroxine for 4 weeks or liocyanine for 2 weeks, or we can continue thyroxine and give Thyrogen as an alternative method. So, the assessment of TG should be checked at least 6 weeks, not before 6 weeks. This is a patient, young female, presented by 0.9 centimeter thyroid nodule, U3, no history of radiation exposure. No, she had a family history of thyroid cancer, no cervical lymph node, thyroid function is normal, fine needle aspiration cytology, well differentiated papilla thyroid carcinoma. So don't forget that this is a well differentiated thyroid carcinoma, no invasion, absence of any regular or distant metastasis, underwent lobectomy. Which one of the following is the most appropriate further management approach in her case? External beam radiotherapy, radioactive iodine ablation post-operatively, maintain TSH between 0.3 to 2, measure of stimulated TG, suppress TSH less than 0.1.
By exclusion, suppressant no. Ablation post-operative no. External beam radiotherapy no. I think measurement of stimulated TG.
Why? What is the value of measurement of stimulated TG in a patient already presented with another healthy loop? The value of TG if the patient already do total thyroidectomy, because the presence of positive TG means the recurrence. But actually, in our case, the patient is doing lobectomy. There is another healthy loop. In this condition, will secrete more and more TG. What?
Why?
Suppress TSH in the patient. What about the risk stratification of this patient?
Another loop.
What about the risk stratification of this patient?
Low risk.
Low risk. What is the target of the TSH in low risk?
0.5 to 2.5.
Lower half of the normal. So what is the target of the TSH here?
0.3 to 2.
0.3 to 2.
Yes, yes. So in this situation, the patient is doing lobectomy. So radioactive iodine post-operative is not a good option. Also, stimulated TG is not a good option. So a suppression of the TSH to less than 0.1, this is upward in a high risk group. In this
Excuse me,
patient
doctor.
presented by papillary microcarcinoma and doing lobectomy, the ideal is to maintain TSH2 between 0.3 to 2.2, and this is the target for low risk follicular cancer or papillary thyroid cancer. And the radioactive iodine remnant ablation is not needed, and the thyroglobulin is secreted by normal thyroid loop, so the follow-up by thyroglobulin is not an appropriate in this situation. And actually, this patient not require remnant radioactive.
Excuse me, doctor.
Yes.
There is the same question in the best of 5, first edition.
Yes,
And
which
the answer
question?
is measured
Which one? If
best of
you
5, first edition. First edition.
this is
not
the first
second.
edition. Yes.
Yes. Also, 58
Question.
number.
58.
It's a number.
This is one. This is one.
Yes. 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 Same question.
Yes, external beam irradiation measurement of stimulated whole body scan. I will show answer to check it.
There is different in the choice.
Yes, I know
Khalid,
that. Yes,
MCQs and
yes.
because they are different.
And actually, this is a different. Actually, some of question in first edition is different than the second edition. And actually, if you see the question, I will go to the this question here to try to answer it. The same question actually. External beam radiotherapy is not correct one. Ablative post-operative is not correct one. PET scan is not correct one. Whole body scan after 6 months as there is another loop is not correct one. So in this situation, measurement of stimulated TG is the most accurate option regarding other options. But actually in a clinical practice is not the correct one. So Prof Atul is change this option in the second edition because this is not a logical one. For this condition, I think Prof Atul changed and updated this book because this is a not logical option. And if we read, patient with low risk follicular cancer or papillary cancer less than 1 centimeter may be treated with thyroid lobectomy. Ablation operative is not needed. Suppressive dose of thyroxine should be started with aim to keep TSH is less than 0.5. TG measurement after TSH stimulation should be arranged at least 6 months after thyroidectomy. Whole body scan is usually not required. But what is about the value of the TG? Actually, another healthy loop will secrete TG. So the assessment of TG in this case scenario is not the ideal option.
Also, point of suppression dose less than 0.5. This
actually,
point is not accurate. Yes.
This is not accurate one. And actually, if you see the second edition, I think the second edition. I will go to the answer.
The second, not the first edition.
This is the second edition. And the question is, this is the number, this is from the Atul book. So this is updated numbers, maintain TSH at 0.3 to reference range. So this is
when I prepare for exam, I will read the second edition, not first.
Actually, if you cannot conclude this is the patient is low risk in this situation, I will choose to target of the TSH is less than 0.1. But actually, in this clinical case scenario, microcarcinoma is a very, very benign condition. The most benign thyroid cancer is thyroid papillary microcarcinoma. And here he mentioned in this second edition, TSH level should be maintained at 0.322. So in exam, if your patient, you face a question like this, please choose the answer. The target of the TSH is between 0.3 to 2, like the second edition of Atul book. Another question in the toolbox. This is a patient presented by medullary thyroid carcinoma, and the 24-hour urine metanephrine measurement was within normal, so pheochromocytoma is excluded. Which one of the following is the most appropriate step in hair management? Chemotherapy, external beam radiotherapy, somatostatin, total thyroidectomy and lymph node dissection, total thyroidectomy followed by radioactive iodine ablation.
Total thyroidectomy followed by
lymph node dissection.
Total thyroidectomy followed
Lymph
by
node
radioactive iodine.
Radioactive iodine or lymph node dissection?
Lymph node dissection.
So, radioactive iodine is not appropriate for medullary thyroid carcinoma. Radioactive iodine and suppressive therapy is only allowed in differentiated thyroid carcinoma, medullary, follicular, and papillary only. Medullary thyroid carcinoma is treated by total thyroidectomy and lymph node dissection. Lymph node dissection. And usually lymph node dissection is level 6 lymph node dissection. And this is a summary from a British Thyroid Association guideline for management of medullary thyroid carcinoma. Initial evaluation by sonography, fine needle aspiration cytology, calcitonin, and we should go to the genetic counseling and red gene mutation. We should screen for men 2A and 2B by doing calcium and parathyroid hormone for hyperparathyroidism primary, and doing 24-hour urine-free cortisol to pheochromocytoma, and the treatment by total thyroidectomy and level 6 lymph node dissection. Prophylactic surgery for the patient who have a disease-free carrier of germline rate mutation before the age of 5 in men 2A, and age of 1 year prophylactic surgery if men 2B patient gene carrier. Lifelong follow-up. And actually a level 6 lymph node dissection, this is important. This is a level 6 lymph node dissection. But actually in a case of papillary thyroid carcinoma with lymph node, we will go to level 5. So in a case of medullary thyroid carcinoma, we will go to level 6 lymph node dissection only. This is another question about a patient presented incidentally detected FDG activity the thyroid gland during a routine PET CT scan during pancreatic carcinoma staging. The patient presented heart rate is normal with no tremor, no eye signs, no visible or palpable thyroid nodule, but a PET scan showing detected focal thyroid lesion, no cervical lymph node. Which one of the following is the most appropriate management approach? Discharge from a clinic, radioiodine ablation, repeat PET CT, refer for surgery, thyroid sonography. What is the best option?
Ultrasound.
Thyroid ultrasound عشان الريسك.
Yes. Thyroid ultrasonography is the first choice in assessment of recurrence. In any patient, if you assess thyroid cancer, please do thyroid sonography as a first step. And as I mentioned previously, sonography is the first step. If normal thyroid sonography is CT, if CT, bone scan, after bone scan, PET scan. But here, all incidentally detected focal uptake in the thyroid gland by PET CT, we should go to thyroid sonography. If thyroid sonography in this situation presented by thyroid nodule, what is the next step?
Fine needle aspiration.
In a case of normal or elevated TSH, actually don't forget, if we find a thyroid nodule, we should go to TSH. If TSH is normal or elevated, the second step is doing fine needle aspiration cytology. If it is thyrotoxic low, in this situation, the next step is thyroid scan. So this is a very important. In any thyroid nodule detected by PET scan, we should assess by fine needle aspiration cytology. This is a patient, a nuclear physics professor, was referred for advice before taking up an overseas position, overseeing the dismantling of the reactor at the site of recent nuclear accident. She stated that she would face a small risk of being exposed to significant radioactive iodine contamination during her work, and was concerned about her future risk of thyroid cancer. What is the most appropriate advice? Avoid consuming local milk and vegetable. No precaution are necessary because the age is less than 40 or more than 40. Take potassium iodide tablet. Take selenium tablet. Wear lead neck shield while outdoors. What is the most?
Potassium iodide tablet.
B.
Take potassium iodine.
Don't forget, as I mentioned, take potassium iodide tablet is the most important to prevent increase the risk of thyroid cancer, especially follicular thyroid cancer actually. So, the potassium iodide tablet is the most appropriate advice if you think he increase accidentally have exposure to radioactive iodine. This is a patient, presented female patient, for 55-year-old female, 4 centimeter papilla thyroid cancer, treated by surgery, radioiodine, undetectable thyroglobulin, but high titer of thyroglobulin antibody. What is the most appropriate investigation at annual follow-up?
Ultrasound.
Scan
of the neck. Ultrasound.
Ultrasound
High titer
or whole body iodine uptake scan? 4 or 5?
Ultrasound scan.
we can't rely on thyroglobulin because of high titer of anti-thyroglobulin.
Once the anti-thyroglobulin antibody titer is positive, the undetectable thyroglobulin is maybe a false result. So we cannot depend upon undetectable thyroglobulin. What is the best option to assess recurrence?
Ultrasound.
Yes,
Whole body.
ultrasound is
Ultrasound.
the best option. Don't forget that the ultrasound scan is the most sensitive investigation for detection of locally recurrent thyroid carcinoma.
Dr. Khaled,
Yes.
if the antibody came positive, but thyroglobulin is high, detectable, shall we depend on it or?
Yes, we should depend on it, and we should investigate, and we can diagnose the recurrence, but we should search for a site of recurrence. If it is in the thyroid bed, this can be discovered by thyroid sonography. If outside the thyroid, so we should go to the CT chest and maybe need thyroid bone scan or PET scan. So if TG is detectable with, even if an anti-TG antibody is positive, this will denote recurrence. So we should investigate for recurrence. This is another patient presented by paleness, rapidly enlarging right neck mass, pressure on swallowing, voice had become quieter, and a large mass 6 by 5 centimeter, diagnosed as anaplastic carcinoma by fine needle aspiration cytology, and also invading strap muscle. What percentage of patients with this stage of the disease survive for 12 months? And usually in the exams you will ask a question numbers.
Prognosis must less than 5. It's poor prognosis.
10 to 20%.
So this is the correct one. So the poor prognosis, but actual the risk of survival, stage of survival is about 10 to 20. Anaplastic carcinoma of thyroid has a poorer prognosis. A 12-month survival is unlikely, but may occur, and this is the percentage of it. And this is actually question from the official European Board Examination website. So this is the correct answer, not less than 5. Yes, this is another question. 17-year-old background history of medullary thyroid carcinoma with surgical resection and presented with solitary cervical lymph node, and fine needle aspiration cytology shows a feature of metastasis from medullary thyroid carcinoma. What is the most appropriate step in the management? Metastasis from medullary thyroid carcinoma, cervical lymph node, cervical metastatic lymph node, external beam radiotherapy,
external beam radiotherapy,
radical neck dissection,
Radiotherapy.
radioiodine ablation, suppressive dose.
Maybe
Actually,
1 or 3.
Maybe radical
external.
dissection.
actually, this is a recurrence and
Metastatic.
present in the neck, accessible cervical lymph node. So how to treat this lymph node?
Radical neck
Dissection.
Radical neck dissection. As even if there is a recurrence in the thyroid bed, what is how to manage? Actually by surgery. But if the surgery is not available or contraindicated, external beam radiotherapy is an alternative therapy. But don't forget that radioiodine ablation, a suppressive dose, is not appropriate in a medullary thyroid carcinoma. So a radical neck dissection is the best option in the management of solitary cervical lymph node metastasis from medullary thyroid cancer. And this is a question from study BRN 2022. Yes?
Dr. Khalid, according to her risk medullary cell carcinoma في السيرجيكال ريسكشن، مش كان المفروض يتعمل من البدايه راديكال نيك ديسكشن مع الريسكشن بتاع الجلاند؟
But actually for medullary thyroid carcinoma usually they resect stage 7. So they are not doing radical lymph node dissection, just level 6 in a case of medullary thyroid carcinoma. Because
17-year-old maybe do thyroidectomy before diagnostic as thyroid.
In a case of men, in case of men 2A or men 2B. This is in a case of men 2A or 2B. In this situation, we should go to prophylactic thyroidectomy before the age of 5 or 1.
Yes, without resection. I think total thyroidectomy without
total thyroidectomy alone. Total thyroidectomy alone.
Yes.
Yes, okay.
We near the end. This is a patient, 44-year-old female, presented by papillary thyroid cancer, 3 cm, treated by total thyroidectomy with central lymph node dissection. Received already radioactive iodine ablation and asymptomatic, but a blood test in the follow-up elevated thyroglobulin. TSH is less than 0.01 on thyroxine 200 microgram daily. The thyroglobulin autoantibody are negative. The ultrasound of the neck plus whole body scan are negative. Which of the following is the most appropriate next step in the management? Decrease thyroxine, PET scan, radioiodine ablation, repeat thyroglobulin level in the 3 months, surgical exploration.
PET scan.
Which one?
PET scan.
PET scan.
What about surgical exploration?
Patient already have central lymph node dissection.
And actually, surgical exploration for what? For neck or for metastasis to the bone or metastasis to the lung or what? So surgical exploration is not.
She is asymptomatic.
Yes.
Even in a patient is asymptomatic, so we have 3 options. Sonography is the first one. The second one is CT scan if it is available, CT neck, CT chest, bone scan, and if these options are normal or not available, the PET scan is the next one. So in this situation, we cannot decrease the thyroxine dose. We cannot give radioiodine ablation. And actual radioactive iodine ablation is one option if we cannot find, as I mentioned from the tool book, that in any patient with elevated TG, we have 3 options. One of them is to give empirical radioactive iodine, but in the exam, PET scan is the best option. And actually, I think this is the last question in this session. This is a patient, 32-year-old lady, papilla thyroid carcinoma, treated by total thyroidectomy and post-operative radioactive ablation since 3 years. Already on thyroxine 75 microgram per day, no palpable cervical lymph node, labs are normal, FRET4 is normal, TSH is normal 2.2, the anti-TPO is negative, the corrected calcium is normal. What is the most appropriate next step in the management?
Increase thyroxine dose.
Decrease or increase or leave it the same?
increase علشان نخلي TSH لحد 0.1.
Yes.
Because patients received post-operative radioiodine ablation.
So the target of the TSH is less than this number, so we should increase thyroxine dosage. So this is the last question in my session. So I will summarize this thyroid cancer session. This table to compare papillary and follicular and anaplastic thyroid cancer. Don't forget that the papillary thyroid cancer is spread by lymphatic, but the follicular and anaplastic by hematogenous spread. The papillary and follicular thyroid cancer, this is a differentiated thyroid cancer treated by surgery, total thyroidectomy, TSH suppression, and radioactive remnant ablation for high-risk patient alone. How to follow up? Usually by total body radioiodine scan plus TG measurement, and thyroid sonography is a very important tool for follow-up. Anaplastic treated by external beam irradiation and chemotherapy, and of course total thyroidectomy with lymph node clearance is the first option. Because the target of the TSH, actually, if you can conclude that your patient is low risk or intermediate risk, deal with it as your target TSH is less than 0.1. In this situation, if our patient low risk or no, actually we have no data about the histology of thyroidectomy, if there is invasion or not.
I think this patient no low risk because she received post-operative radioiodine. Maybe
yes, and even if this is not one, we cannot be sure that this patient is a low risk. In this situation, please, your target TSH is less than 0.1. Most of patients who need radioactive iodine ablation mostly intermediate to high risk, because low risk patient no need for radioactive iodine ablation. Also, in a case scenario, if they not mention that this patient is low risk by histological type of cancer, for example, the size of the tumor, lymph node and metastasis pattern, in this situation, please deal with a high risk thyroid cancer. And in this situation, TSH target will be less than 0.1. To decrease the TSH to be less than 0.1. And this is the oncogenes and the tumor suppressor gene, which you need to memorize. The papillary thyroid cancer BRAF gene, follicular thyroid cancer BAX8 and BPAR gamma-1 fusion and RAS mutation, anaplastic TP53 and medullary thyroid carcinoma rate proto-oncogene. And don't forget that follicular adenoma RAS mutation and toxic adenoma TSH receptor activation mutation GS alpha mutation. And this is a risk factor for thyroid cancer. Don't forget Hashimoto's thyroiditis increase the risk of lymphoma, endemic goiter, and obesity will increase the risk of thyroid cancer. And the thyroid nodule is more likely to be malignant in a young patient or elderly patient, and if there is a microcalcification. And don't forget, if there is invasion like Hurthle of voice or bulbar cervical lymph node or rapid growth or firm solitary non-toxic nodule, this will increase the risk of malignancy. The risk stratification of recurrence of differentiated thyroid cancer is very important to memorize. In low risk, there is no focal, local, or distant metastasis All macroscopic tumor has been resected. No tumor invasion. The tumor does not have aggressive histology. High risk extrathyroidal invasion, incomplete macroscopic tumor resection R2 or distant metastasis. In this situation, this is a high risk group. A TG and the TSH, TG antibody should be assessed simultaneously. For patient in remission, TG and TSH on annual basis. No need for TSH stimulation if the basal serum TG is already detected. In the presence of rising TG, we should investigate to localize disease recurrence by sonography, CT scan of the lung if sonography is normal, bone scan if the neck sonography and CT of the lung are normal, and last option is the PET scan. And this is how to manage a patient with papillary thyroid cancer more than 1 centimeter. TG level should be checked at least 6 months, 6 weeks after surgery. Radioactive iodine ablation, if done, should be arranged within 3 to 6 weeks of thyroidectomy. Suppressive dose should be restarted 3 days after ablative therapy, and the recommended target of the TSH is less than 0.1 in high risk group. Whole body scan if done after 9 to 12 months. And this is how to manage medullary thyroid carcinoma according to the British Thyroid Association guidelines. Genetic counseling and rate gene mutation is very important if you suspect or screen for 2A and MEN 2A and 2B. Sonography finding aspiration cytological screening is the initial evaluation. Prophylactic surgery before the age of 5 in MEN 2A, before the age of 1 in MEN 2B, and lifelong follow-up. And total thyroidectomy is the first choice for treatment with level 6 lymph node dissection. And actually, this is the end of thyroid chapter in Oxford Handbook, both 3rd and 4th edition. And actually, we have still have some of important topics to discuss, inshallah. We have to discuss the thyroid guidelines. We need to discuss practical thyroidology, practical aspect of thyroid disorder. I will revise this chapter. And actually, I already do a previous general revision for thyroid chapter, so I will not repeat general revision for thyroid, already available in the YouTube channel. So it is available already, so you need to revise it and listen to it. And also we need to revise the previous exam question, thyroid question, the previous 6 years. And also we need to do solving question exam lab, a toolbook, website, and some of the question of study BRN and non-examination and another sources. So it is very important to collect this banks for question study BRN, exam lab, practical diabetes, on examination, and a website. And actually I send the PDF files for this question for who subscribe with me in this paid course. This is the study BRN, and this is on examination 2022. This is the updated version from study BRN and on examination. And also I send exam lab questions. This is the same as the previous one. And also practical diabetes is the same as the previous one. No update for practical diabetes. This is the same question as the previous one, but I select a question and answer for thyroid and send it. And also I update the official website questions and send this file to all who subscribe with me. And lastly, inshallah, in the next presentation, I will cover the thyroid guidelines. And actually, thyroid guidelines is very important topic. Inshallah, in the next Friday, and I will cover the most important guidelines published by NICE, European Thyroid Association, British Thyroid Association, Society of Endocrinology, and EU-GOGO. And I will cover actually the most important one, which is a NICE guidelines for thyroid disease and assessment published in 2019. and also I will cover thyroid cancer guidelines published in 2014 by British Thyroid Association, and also I will cover the most important guidelines published by the European Thyroid Association about the combination therapy, TSH-HOMA, subclinical hypothyroidism, subclinical hyperthyroidism, and also I will cover checkpoint inhibitor guidelines, central hypothyroidism, amiodarone, Graves' hyperthyroidism in adults, and another very important guidelines in pediatrics. I will cover it, and also I will cover Graves' orbitopathy, and I also will cover thyroid disorder prior to and during assisted reproductive technology, and also I will cover pediatric Graves' disease, and also I will send this PDF file to who subscribe with me after this session, inshallah. And also I collect another guidelines, but actually in the next session I will not cover American guidelines because this is a very difficult topic to cover, but actually I collect all guidelines related to the thyroid from the American Thyroid Association, from Endocrine Society, from ACE guidelines, from NHS, and collect and ESMO guidelines for thyroid cancer. This is the most important updated guidelines published on the thyroid cancer. I collect this file, and inshallah I will post these two parts, part 1 and part 2, for thyroid guidelines to subscribe. And actually this is guidelines which I will post. This is the guidelines. Part 1, actually this is the most important to study in the exam, for the exam, and this is you can go to anyone. This is a very important one and not highlighted. And another one which is part 2, which is American, and another important guidelines. This is the part 2, and actually this is a very large PDF file. This is more than 800 papers of guidelines. American, this is just if you want to collect all thyroid updated thyroid guidelines, and this is the ESMO guidelines for thyroid cancer, the latest one. And actually all of these guidelines are already available freely in the website. Anyone can collect them, but actually I collect it in a one file, and inshallah later on I can collect the highlighted guidelines like this, and I can upload it in a separate file to try to read it, the highlighted one. So I already highlight the most important section in each guidelines like this, and inshallah later on I can upload this later on, but actually I will upload non-highlighted guidelines. So if anyone yes, Dr. Asana, did you send already the MCQs for? Yes, and actually I send it to you, Dr. Asana, through my phone, and actually I do some sort of list. If you did not not through email, just through WhatsApp group. So if you didn't receive it, I will send it to you separately. But actually, I make a group in the WhatsApp, and for who not saved my phone number in his phone, the group this is known as in the WhatsApp. New broadcast message will not be sent to you. So please save my phone number in your mobile, which ended by 40. So anyone not receive a PDF file, please let me know. And for anyone in the subscribe group, if he not receive the recorded sessions, please let me know, and I will solve this issue. So if anyone has any question, it is welcome. So I will send it to you, Dr. Sanem.
Shukran.
The next Friday I will start. Okay. Yes, I will send it. Inshallah, in the next Friday, I prepare already this guideline, but actually it is a very large guideline. I cover all important guidelines. As I mentioned, it is about 200 slides. I don't know if we can complete it in one session or need more than one session. So I hope to complete it in the next Friday. If not, so we can complete it in 2 sessions, inshallah. And after that, I will go to the questions to solve a toolbook and study BRN and the most important question, inshallah. So if anyone has any request, it is welcome. Can we have our session leaded area Cairo time 4 p.m. Dr. Shavan? And actually in the next Friday, I don't know if it is 4 p.m. Available for me or not, but I can let it 5 p.m. inshallah in the next Friday because I go to my village inshallah. So see you later inshallah in the next Friday.
شكرا بارك الله فيك.
السلام عليكم ورحمة الله وبركاته.
شكرا يا دكتور خالد. السلام عليكم.
وعليكم السلام.
دكتور خالد يعطيك العافية.
I have Dr. Rana. We have 2 numbers, Dr. Rana. One ended by 123 and another one ended by 40. So there are 2 numbers, not 1 number. And actually, I send it from the one ended by 40. I think this is the number. I think this is to be sure. This is the number. I think this is the number. This is the number which I send from it, the WhatsApp group. So for all who subscribe with me, this number must be saved in your local phone. If you did not save this phone number, actually I send through broadcast. And the broadcast mentioned that if the receiver did not save my number, he will not receive my message because I cannot send for everyone separately. I didn't, so I will send for Dr. Rana and Dr. Sana, and please save my number. So I will send it after a few minutes, Dr. Rana and Dr. Sana. Thanks to all. Inshallah, see you later. Inshallah. Salam alaikum. And also, I will upload it once completed, inshallah, today or inshallah tomorrow, once finished compiling this file.